Welcome everyone to Benevilla's Fall Caregiver Connect. We are so happy that you joined us today, and we're so grateful for everything that you do for us in the community. I want to introduce myself. My name is Joanne Thompson, our President CEO of Benevilla. I want to thank our wonderful staff and the City of Peoria for putting our Caregiver Connect together. It has been an amazing journey through this COVID, and we've had to pivot every way, and the City of Peoria has been such great supporters of us to be able to broadcast this live to you. And I also want to thank Taylor. She is our Director of Marketing, and she has been wonderful putting these events together, and she's actually moving to Nashville, so we will definitely miss her. So thank you, Taylor, for everything that you've done for us. We want to wish you well this holiday season. If you need anything, any caregiver resources, if you just need to talk to someone, if you need respite, we are here for you. So please reach out to Benevilla for anything that you need. If Benevilla can't do it, we will find someone that can help you. Today is an exciting day. Today is actually Giving Tuesday, which is the start of our giving season for the holidays. We could not do all that we do for the community without our community support. It has been amazing during COVID, and we have not stopped services. We still are continuing services. We do grocery shopping for seniors who can't drive anymore. We take them to doctor's appointments. We still have our life enrichment programs open to provide respite for our caregivers, our free caregiver support groups. And actually, Giving Tuesday, we have a dollar-for-dollar match for $10,000 that's going to go directly to all of our caregiver resources. So please consider donating to Benevilla today. You can call 623-584-4999. You can go to benevilla.org, or you can go to our main campus. But we would love your support. Now today I have the exciting opportunity to introduce Dr. Neary. So Dr. Neary and I met about 14 years ago, and we were walking into a program, and Dr. Neary was actually the speaker of the program. And I was so amazed at everything that he was talking about to the crowds about the reduction of medication, helping people with dementia. It was so awe-inspiring. So let me tell you a little bit about Dr. Neary. He's the Associate Program Director and has been the Program Director for the University of Arizona College of Medicine Phoenix Family Medicine Geriatric Fellowship Program for over 25 years. And actually, a lot of his fellows come into our programs to help those people with dementia and our caregivers. The program educates both family medicine and internal medicine physicians to become geriatric practitioners. Since 1996, there has been over 75 graduates, and they're actually staying in the Phoenix area, which is amazing. He's also the past director of the Banner Sun Health Research Institute Center for Healthy Aging in Sun City, Arizona, and past principal investigator for the Longevity Project, Learning from Our Elders. In addition, because he's got so much time, he's also the medical director of several long-term care facilities, including Auberge in Peoria. That's a dementia-directed assisted living facility in the Sun City area. He is also Hospice of the West medical director. Dr. Neary has a specific interest in healthy aging and developing innovative models of care for long-term care and for those who have dementia to ensure they have the best quality of life. Please help me welcome Dr. Neary.
Thank you, Joanne. I appreciate that. And thank you for inviting me to this wonderful conference and very, very important conference. So today what I'd like to do is I'd like to talk a little bit about how our older patients think a little bit, as well as how we think about our older patients, and then talk about some innovative models of care that we're instituting relative to how do we provide the optimum care for our older adults. So let me start by saying geriatric care, what is the difference between the caring for an elderly patient and in comparison particularly to a younger patient? And what is our own perspective about caring for our older person? So let me start maybe a little bit. We all can relate to this as we get a little bit older. And so these are little sayings that I thought were kind of neat. I love being 80. I learn something new every day and forget five other things. I think I'll just put an out of order sticker on my forehead and call it a day. It's weird being the same age as old people. As I get older, I keep reflecting on older people and say, I'm not there yet, but yet you do. You're part of that age group. I'm getting tired of being a part of a major historical event. What's this? When I teach for our young geriatric fellows, for example, and I'll comment about we'll just say Tony Bennett, since it's fresh on my mind, and they'll say, who is that again? And so all of a sudden I have to realize I am getting a little bit older. And when I was a kid, I wanted to be older. It's not what I really expected. And I'm at a place in my life where errands are starting to count as going out. So some of these things are actually a reality that we have to look at and how they are thinking. On the other hand, a popular term nowadays is called ageism, which is the definition is prejudice or discrimination against a particular age group and especially the elderly. Why do I say this? And it is, again, something that's in the news a lot, but as it reflects as far as health care, it's a very important issue as it relates to how we manage our older adult patients. So what are some examples of ageism in the health care? Provider dismisses a treatable pathology as a feature of old age. We'll talk a little bit more about that later. Or on the contrary, providers treat the natural effects of aging as a disease, and we start treating something that probably really isn't a reflection of an underlying disease. We share and laugh at ageist jokes. I think humor is always good, except if it's part of a negative impression or perception of an older patient, then it probably isn't very good. Providers have an implicit ageist thoughts, feelings, and behaviors towards the elderly. How do we treat our older patients? They apply stereotypes, the old gizzard, for old buzzard, if you will. Elderly adults also, if you talk about with multiple chronic illnesses, are often excluded from clinical trials. This is very important, as I'll go into a little bit later, in terms of one shoe doesn't fit all, and particularly as it relates to our geriatric patients. So ageism versus a medical condition. I guarantee you if you talk to a 30 or 40-year-old individual and they have a little bit of pain, they might reflect it's due to a sprained ankle, for example. If they're fatigued, I'm working too hard. I can't remember certain things. I'm a little sad today, a little anxious. And on the other side of the coin, when somebody describes themselves as an older person who has fatigue or pain, do we pass this off as you're just getting old? Particularly with regards to depression, for example, part of that would be fatigue. But when someone comes in maybe with symptoms of depression, we overlook those and try to attach a medical problem to that. Obviously, people who start forgetting as they get older, the first thing is, I've got Alzheimer's dementia. Or you're getting old is a typical response perhaps by the provider. So we always have to be aware of that. How do we interpret these symptoms relative to age versus disease? Communication issues are also a problem with our providers and caregivers. For example, less patient. Our older adults take a lot more time, and therefore we have difficulty maybe because we're always in a hurry, trying to make sure that we're in a hurry and we push our patients, ignoring perhaps something that they're trying to do. Less responsive to their needs. Again, going back to fatigue, well, you're just getting old, no problem. Where maybe we ought to look at a little different perspective and maybe say, is this really maybe the medicines that you're on, for example, that's making you that way? Do we ever treat in an infantilizing manner? I tell you always a story when I first met Dr. Elizabeth Kubler-Ross, who's a prominent physician who was responsible for bringing out her book With Death and Dying. In later life, she experienced a stroke and was confined to a wheelchair. And when I first met her in anticipation of her speaking at a conference, I bent down to her and I spoke very slowly and loudly. And if you'll pardon me, she says, "I'm not goddamn deaf." And it was just terrible. I mean, it just caught me off guard because I prevented I committed that major mistake, or faux pas, if you will, of treating her like an infant. So that just gives you a classic example. And for a patient, for example, that appears to be cognitively impaired, maybe this is just the fact that this patient is a hearing deficit and therefore can't hear quite as well, and maybe we're interpreting that as a cognitive impairment. So mentioning that, conditions that may complicate communication with providers, sensory deficits. So if a patient can't hear and we're talking to a patient, typical thing and their response would be, yes, you understand, and yet they didn't really hear most of it. A memory impairment, okay? So if we talk too fast, they're liable not to comprehend what we're saying, and so therefore we have to take that into consideration when we're communicating. And much as I mentioned with Dr. Kubler-Ross and being confined to a wheelchair, we treat people differently. Now, you note I said people differently when they're in a wheelchair, as opposed to that they are a person. So, what steps, and this is the exciting part of what's going on not only in our community but also nationally. Because ageism in healthcare does exist at all levels, to combat this, it requires implementing a strategy that involves training healthcare providers, all right, revising institutional policies and procedures, and addressing ageist attitudes in elderly patients. Back in 2017, a group of organizations headed by the John Hartford Foundation developed what was called the Age-Friendly Health Systems Initiative. Fascinating initiative. But basically, it's guided by an essential set of evidence-based practices. It causes no harm and is consistent with, very important, what matters most to the patient. So how is this all going to affect our healthcare system, for example? Well, one of the ways is we have in healthcare in general, we talk about medical care. Providers provide medical care. We're looking at this in a more holistic approach and talking about health care, for example, and not just medical care. So they developed the 4 M's, all right? Now the 4 M's, I'm going to start with the bottom, is mobility, for example, all right? Can these older adults move safely? Keep in mind one of the common conditions of our older patients is falls. So what are we doing to address the prevention of falls? Mentation. Memory problems are a major issue. However, is this really a memory impairment? Could it be depression, or could it be dementia or delirium, for example? So we call that the 3 Ds. The big issue in geriatrics, of course, is medication. Our healthcare system is set up that we provide, each specialty, I should say, provides medication for each organ system. The end result in a geriatric patient with multiple problems, they may be on multiple medications. And the question really comes up is the way that they feel related to their medications, or is it related to their disease? And we try to do a good job relative to determine which one it is. And lastly, what's most important, we need to talk to our patients. What matters most to this individual? We have to incorporate them into the decision-making processes. If you go into a hospital, you're almost excluded from the healthcare providers, in a sense, from them wanting to give you their treatment for this. Oftentimes we don't ask the patient, however, what they might want and what kind of treatment they may want. I went over the 4 M's framework I've already mentioned in mentation in terms of talking about, is this dementia, is this delirium, or is this depression? From a mobility standpoint, we ask, how stable is the gait on this individual? How close are they to a fall that could result in a fracture and hospitalization? We look at how they're able to do their ADLs, for example. Are they able to dress themselves? Are they able to go to the store? Are they able yet to drive, for example? And then medications. This is a big issue in geriatrics and providing care. And for caregivers, we always have to say, make sure that you go over their medications and discuss with the primary care provider, are any of these medicines not appropriate, or are they associated with any side effects that we might alter them and provide a better quality of life for the individual? And then lastly is we talk about person-centered care. We have to bring the person involved into the discussion and the decision making. Talk about prognosis, but really in the term, what benefit is there for some of the medicines that we prescribe perhaps to a younger individual, but yet we prescribe and may not be appropriate, however, for our older patients. And lastly, let's talk about the future. I mean, the time is short, and we may or may not have much time, so let's talk about it. I briefly want to mention that in this healthcare initiative, for example, or age-friendly care, we really have to look at an age-friendly community. So I'm not going to go into these details, but we look at appropriate housing, transportation, respect and social isolation, communication, civic participation, one of which we're doing right now, community support and health services, which Benevilla does such a great job, and outdoor spaces, for example. And the classic thing is, do we have an appropriate place for our older patients to drive? And we see a lot of golf carts in Sun Cities, and I think that's important. It allows them to go from point A to point B without necessarily having to drive a car. And lastly, social participation. We need to provide those activities for our individuals. So what's the difference between traditional medicine and geriatric medicine? Well, let's take a look at it. So if you really look, you hear the term maybe evidence-based medicine, and this goes all the way down to the caregiver. And now, unfortunately, you're reading it even on the internet. What is the best way to treat this? All right, and that evidence sneaks into social media, and even our patients and caregivers read that and say, maybe this is what we should do. However, if we really look at evidence-based medicine for geriatrics, a lot of the studies, as I've alluded to, are associated with clinical studies that involve mostly younger patients and not older patients. So therefore, our clinical expertise might be limited in terms of how we approach this patient, particularly those who take care of older patients. And we have to really assess the patient's value system and what matters most to them. Geriatricians, in turn, are taught that the best treatment is based on all three of these. Not only evidence, but what is the clinical experience based on that evidence for our older adult patients, and then really to discuss with the patients, what are your values and what do you really want? So geriatric medicine, and I'll read this, is biologically and socially old age begins for most people between the ages of 60 and 70, and geriatric care should begin then. Geriatric specialists focus on the care of elders, the way pediatricians focus on the care of children, and internists focus on the care of adults. Stop and think about that. If you have young children, most people take them to a pediatric doctor. For geriatrics, we take them to a family medicine doctor or an internal medicine doctor, but maybe the geriatrics who is most trained to deal with these older adult issues would be the primary provider in providing the care in this particular case. Currently, there's 67,000 pediatricians, but there's only 6,000 geriatric physicians. Geriatric specialists have expert knowledge, skills, and training in aging, health, and disease across the decades and different stages of old age, if you will. I like this little comment because a lot of people will say, what is a geriatric physician? And in this cartoon, he's our geriatric specialist. Looks a little old there. All right. Geriatric care, again, compared to traditional care, if you will, that you would see, is in general, we look for a cure in younger individuals. You have a cold, you go into the doctor's office and you get treated and you're fine. With geriatrics, we're talking about an individual may have 3 or 4 different chronic medical problems, and we're not going to cure those medical problems, but we really do have to care for those and carry them through till their end of life, if you will. When you go into a doctor's office, you see a list of diseases: hypertension, hyperlipidemia, heart disease, chronic kidney disease, whatever it might be. But we look at it as an illness, for example, and an illness includes the personal and social consequences, all right, of the disease as well as the medical aspects. For example, what are the impairments, what are the disabilities, and what are the handicaps? How can we address those? So in traditional care, the other thing that we see, it's episodic. You're fine, your blood pressure's fine, your heart's fine, your weight's fine, I'll see you in a year. In somebody who has multiple medical problems, things change in a short period of time, so they need to be followed more frequently. Traditional medicine, we react to the needs. Classic example is patient falls, gets a hip fracture, all of a sudden everybody gets excited, whereas we anticipate in geriatric care that this patient may fall, and what are we doing to prevent that fall that results in a fracture? Our older adults at this particular time have a passive way of talking to their physician, whatever the doctor tells me. I see this so frequently. I'll talk to a patient, what did this doctor tell you? He told me I had this, and I need to do this, and that. Not really incorporating the patient's wishes or their participation in making the decisions on what to do. In geriatrics, it's also a team approach. Every caregiver that's out there is part of that team, and it's a very important part of that team. It takes a team of individuals taking care of an older adult to make sure that they have the best quality of life as they go through their illnesses and their older age. It's also a long-term care involvement, so meaning once you take on these older adult patients, it's a chronic care, and you're going to follow them on a continuous basis, as I mentioned. And lastly, it's a very holistic approach. As I say, it's a team approach, and we try to make sure that everybody is included in terms of caring for this patient. So let's start with the basics, though, in terms of caring for the elderly patient. Communication, communication, communication is just incredible, all right? We have to act for an advocate for our older adult patients. Believe me, our older adults need, for a variety of reasons, to have advocates. Caregivers are advocates. Any of the social services or healthcare services, any providers, physicians, nurse practitioners, physician assistants, we have to act for really advocates, as advocates for our patients. Communication means it's a bilateral thing. We need to communicate with our patients. Patients need to communicate with us. We need to communicate with the person's family, for example, and vice versa. And lastly, everybody that's involved, the ancillary staff caring for this patient, need to make sure that we're communicating adequately. Something that I think is extremely important is we talk to people as though they are patients. And I want to say that you really have to know this person more than a patient, but as a person, all right? We're all individuals. And the only way you're going to get to know this patient is if you know this person, so that you can help them based on their value system and what they want through their illnesses as they approach the end of life. I've already mentioned this, but where you take all these chronic illnesses, all right, that an individual have, I alluded to those a little bit earlier, and you're talking about that, what is their cognitive status, what is their gait or mobility status, how many medicines are they on, and do they really need these medicines, and let's have a discussion on what matters really to you. This is very important, particularly at the end of life. In geriatrics, it's a little bit different. If you go in to look at a medical record, oftentimes, as I've alluded to, you will see hypertension, diabetes, heart disease, hyperlipidemia, high cholesterol, and so forth. But we look at a patient a little differently. We call these geriatric syndromes, all right? So most of the times this is associated with some form of disability in which it could be multi-causal. So we look at, I've spent enough time talking about frailty and falls. Do they have dementia? Is this delirium? All right. But do we really look at this patient as isolated? How would anyone feel if you're isolated in a one-bedroom apartment, unable to get out, particularly in the summertime? You become isolated, and depression is very easy to develop. Fatigue, as I mentioned, it's one of the symptoms that we see very commonly. In an older person, it's because you're old age. In a younger person, you're working too hard, whatever it might be. Something that we don't look at, and particularly as we're prescribing expensive medicines, is impecunity, which I love that term, poverty and malnutrition, for example, which are very common. Money is limited in most of our adult population, so it's very difficult to make sure that they can make ends meet. Sleep disturbances, polypharmacy, for example, having too many medications. Incontinence is something that we assume is just age-related, but yet it can be treated. It is a common cause for patients eventually ending up in a long-term care facility. So we look at frailty. It's very important. As a person gets older, our goal is to slow down the development of frailty, which is really a combination of medical, neuropsychological, socioeconomic factors, all of which may lead to frailty. And frailty is linked to poor health outcomes. Particularly the biggest thing is decrease in your functional ability, also more frequent visits to the emergency room, more frequent hospitalizations, nursing home admissions, and subsequent death. Our goal is to try to prevent that from occurring or delaying the progression into that particular stage. And you would be surprised how much you can do for our older adults in delaying frailty, if you will. So they do have a clinical frailty scale, and I'm not going to go into that, but I do want to point to a couple of things, and this is as you go down the list as far as looking at the stages of frailty. Our goal is when you see an older individual, your goal first of all is not to assume that there's no room for improvement, but actually that you can improve these and then you can maintain their functional status, decreasing or then preventing the decline into the frail state where they have a poor quality of life. So we also look at the level of independency versus level of dependency. Why do I really bring this up? And the reason I bring it up is oftentimes patients are admitted to the hospital and they're older patients and the hospitalization knocks them down a little bit. We end up sending these patients home. And one of the big issues in healthcare is rehospitalization. So we're really trying to prevent this from the standpoint of, is it appropriate to send this person at home? What is their level of independency that they can accomplish? And maybe it would be appropriate to start discussion of a higher level of care. And by the way, just to mention on that, a higher level of care doesn't mean, in quote, a nursing home, all right? That's the common perception that I don't want to go to a nursing home, but there's a tremendous alternatives for different types of lifestyle that take the burden of living independently off of an older person who might have some disabilities. As one gets older and the frailty increases, we also want to make sure we appropriately look at the Palliative Performance Scale, and I always put this in, because generally speaking, it does give you an idea of what a functional state of an individual is. This is very important for end-of-life care and for advanced care planning. Speaking of advanced care planning, do we have and understand what the patient's wishes are for the end of life? So we're looking at, do they have a living will? Do they have a medical power of attorney? Do they have a pre-hospital medical care directive, a mental health power of attorney, and several different forms, the post and the mulch, which I won't go into, but are available for our patients as well as our providers to go over with the patient in terms of determining what is it that they really want and what matters to them as they approach the end of life. So, I do want to mention and go over this. For each of us who are listening, all right, ask yourself what really matters most for you when you reach 85 years of age. So let me go over this a little bit better. Again, if you look at your medical conditions, and I know I've gone over this a little, heart disease is still the most common cause of death. So when you go to the doctors, do I have heart disease, for example? Obviously, hypertension is very common in our older adult population and very important to be managed and treated. Diabetes, chronic lung disease, hyperlipidemia, for example, or high cholesterol, osteoarthritis, which is the most common chronic condition in our geriatric patients. What about their eye disease? Do they have macular degeneration, or do they have glaucoma? What about the hearing? So all of these are important, but oftentimes some of these are very stable. The things that we really don't look at that we want to look at, and I would ask what matters to you most. If a doctor comes in and tells you that you're stable in all these other areas, but yet overlooks some of the other things from a geriatric perspective, such as depression. Do you have an early memory loss? Is the early memory loss, as most people would suspect, maybe it's Alzheimer's dementia? But depression could be misinterpreted, for example, as a sign of cognitive impairment. But yet we don't really assess our patients for depression. Depression in the elderly is much different. So how are we addressing that, and how would you want us to approach that when you're isolated, lonely, and depressed? When you're falling, wouldn't you rather have caregivers talking about how can I assist you in making sure that you're not going to fall? And let's discuss that with your primary care doctor, your geriatrician, and let's get you into some physical therapy, and again, going along the lines of a more holistic approach. And what about chronic pain? If a young person comes in and has back pain, chances are, I sprained my back. An older patient comes in with pain, and the first thing said is, you're getting old. Believe me, this happens. And it's something that we really need to address more appropriately. Pain in and by itself can result in falls. The big issue is polypharmacy. This is what we deal with all the time. So stop and think about, each specialist comes in to see a patient and they put them on medications for that particular organ system. I always pick on cardiologists. Forgive me for the cardiologist out there. But nowadays there's multiple medications that they give, and in each of these studies it talks about prolongation of life. My biggest issue is, by the time that you are on 10 medicines for your heart, the likelihood of you having an adverse effect, all right, from the medications is close to 100%. In turn, it's also associated with a poor quality of life. So what matters most is, when I discuss with you, do you want to be on all these medicines and live for another 3 months or 6 months and be incapacitated because of your heart disease or because of all the medicines that you're on? Or should we pretty up the med list and see what works best for you and provides the best quality of life as you approach the end of life? Fatigue is very common, and if you look at loss of independence, the greatest fear of an older adult is loss of independence. And therefore, we really have to address those fears with an individual. Again, the term of loss of independence means I'm going to go into a nursing home, and there's really a lot of alternatives that can occur prior to going into a nursing home that really provides the best quality of care. We also have to address the fears and concerns of the patients and our older adults who say, I don't want to go to a nursing home, and I'm going to say a higher level of care. I want to remain in my home. So these are conversations, though, that you discuss with your patient. Again, you notice that I'm already avoiding the hypertension, the heart disease, the diabetes. I'm addressing other issues that are a major concern for our older adults. And again, this is a team approach, and with communication, we have to make sure that we're all on the same page by discussing for each of us to discuss with each other. Driving concerns, males greater than females at this particular point. That'll probably change, but I look at myself and the last thing I want is to lose my independence of driving. But that is a major issue. What can we do about that? How can we make sure that you're able to drive safely? So again, these are conditions, again, we're not talking about hypertension or hyperlipidemia. When you go to the doctor's office, blood pressure is normal, your heart's stable, I'll see you in 3 months or whatever it might be. But yet we really haven't addressed the issue of driving. How are you driving? Okay? Poverty and nutrition. We call this, in a way, the combination food insecurity. We don't realize how significant that is. For physicians, and again, practicing evidence-based medicine, we're going to prescribe you all these medicines. But you know, at the end of the day, that's going to cost you money. Even though you have Medicare Part D and a lot of it is covered, you still are going to end up paying for a lot of medicines. The end result is do you have enough money for food, all right? Do you have enough money for clothing? Do you have enough money for heat? And the reason I say that is in the summertime, people on unlimited budgets, particularly older patients, take the older person that's in a one-bedroom apartment in the summertime. How do they conserve on the energy that they're spending with heat and the cost of it? They turn the temperature up so that the thermometer up so it's very high, and then it predisposes to dehydration, and then dehydration leads to dizziness when you're walking and perhaps a fall. So these are things that we really have to talk about. Hearing and visual impairment. The latest studies, by the way, do show that people with an early hearing impairment are more prone to develop dementia. So let's assess, do our older adults have a hearing problem, and what can we do about it? How can we address those issues with our individual patients and making sure that their hearing is appropriate as well as their eyes and their vision? Again, visual impairment also leads to falls, for example. I can't see where I'm going. Dark adaptation, for example, is a major issue, so that in a darker room where a younger person may be able to see where they're going, an older patient will take a longer time to adjust to that and therefore may end up falling. Advanced directives, we alluded to that very, very much. It's important to have that. But it's also important for our caregivers and our healthcare providers in general to have a good grasp of that. What are we trying to accomplish in our patients? All right? What is it that they want in their, as far as their issues? Advanced care planning. Why do we wait till an emergency occurs before we've discussed maybe what they want and what they don't want? Should these not be addressed before the patient goes into the hospital with an acute illness? Now, all of this, you've also heard a lot of this relative to the COVID, and we go back to the ageism, and where it was reflected that we are practicing ageism by not treating our older adults as the younger adults are, particularly those that have advanced stages of COVID infections with respiratory failure. But it's very important, and in our hospitals, we've initiated a geriatric consultation service, which has really provided a lot of help for those people with advanced COVID to try to determine what is it that they want, what matters to them, what are their wishes. And going back to what I was saying before, all of these should be discussed in perhaps the physician's office and communicated to all those individuals that are caring for our older adult patients. So finally, whether we like it or not, in geriatrics, our older patients die. So one of our goals is to strive for the best quality of life and not necessarily for the quantity of life. When you ask yourself the question, how do I want to die? When we're taking care of patients, sometimes we really don't ask the patient, all right, we just assume. But when you're treating an older adult patient, reflect upon yourself. If I had what those older individuals have, the multiple medical problems, the illnesses, the disabilities, and so forth, what do I want as I am approaching my end of life? And most people will say, first of all, they don't want to go to the hospital. I'd prefer to die at home, all right? And with as best quality of life as I possibly can with my family around them. And that's really what we really want to do, is we want to provide the comfort care as you and I would want for our patients. And that is the most important thing that we strive for. So with that, I'm going to end, and I want to thank you, and I'm not quite sure we're going to open it up for any questions.
We do. We have a few questions.
All right. That sounds good. I'm ready.
Thank you so much, Dr. Neary. That was fantastic, and I appreciate you taking the time to be here today. So that was great. I'm Tim Hayden with the City of Peoria. I'm the Communications Manager here at the City. This is a live Q&A, so if you have questions, please type them right there into Facebook, and we will get our guest speakers to answer them. And I do have a few questions for you. So let's start with the first one. As a caregiver, how do I start the process of getting the right care for my loved one? Where do I begin?
Well, there are several resources. I don't know if I should throw in a political plug, but Benevilla is certainly out in the West Valley. You want to find organizations that are established and provide the best quality of services and care for our older adults. For example, in Central Phoenix, I think, and more the East Valley is the Duet. So a lot of these are available. I think what Benevilla and Duet and companies like that are doing is making sure that there's enough information in the community that you can address those by calling and getting some information. The Area Agency on Aging is another resource that you can contact. Be careful. There are a lot of advertisements and there's a lot of stuff on social media, for example. So I would look for the organizations that are established and well known in the Valley and then go through them to let them advise you where those services can be obtained.
That's great advice. Thank you. You talked about quality of life. If I see my health declining as a caregiver, what are some of the steps I should take?
Yeah, that's a very important issue. That's a great question, by the way. Caregiver burnout is a very, very common. You know, you want to take care of your loved one, first of all, and so you want to make sure that you do everything, even staying up all night, taking care of an individual. As our caregivers are taking care of patients on a day in and day out, for example, and I'm sure Pam will talk about this a little bit later in terms of how we take care of our dementia patients. It's not easy. It really isn't easy. Lastly, at the end of life, and even if you look at, for example, hospice nurses and aides, for example, constantly dealing with people that die, it does work on you. You do develop an emotional attachment. You have to recognize that. You have to recognize what you're doing. You do need a break as a caregiver, all right? And you have to understand at some point in time, you have to let it go, take a break, and get away from the daily ins and outs of taking care of chronically ill patients. It is an issue, and caregivers should be aware of that. And I think I answered that.
Yeah, perfect. Thank you.
Okay.
Last one here. What steps should I take if I feel like my loved one isn't receiving the appropriate care?
Great question. A great question. I live in perhaps a downsizing. I hate to say it's not a community like Sun City, but a lot of older adults, and so I have a lot of friends that are my age, and they tell me what's going on with their providers, and they tell me how so and so is declining. And I hate to tell you this, I look at what's going on with them, particularly with regards to the medications and how they're being managed, and I shudder. Sorry to say that, I do. So my advice always is to advise them as an advocate. I will advise them as much as I possibly can. But second of all, I have no qualms with giving my opinion and getting a second opinion. And when that second opinion comes up, it's usually with a geriatric physician, all right, who can understand all the illnesses and the medications that's being provided and really address what matters most with each of the individuals.
Thank you. We have one more question come in. And again, thank you everybody that's watching. We love your questions. Feel free to type them right there into Facebook. And if you don't get your question answered right here live on air, feel free to type it in later, and we'll make sure somebody from Benevilla or the appropriate person gets back to you. So last question this time is, when it comes to end-of-life wishes, if someone can't express those themselves, how do you get that information to be known?
That's also a great question. I would start by saying that, first of all, if it's a couple, you know, the loved in a marriage or whatever it might be, a relationship, oftentimes the person that's ill is afraid to say anything about dying because the reciprocal spouse or partner will feel offended because the partner will want to make sure that this patient is living. So you try to get a proper perspective of where both are coming from. I always like to start sometimes by talking to the individual, but I also like family conferences, all right, particularly where there's continued treatment and where it may become futile as far as the treatment, and what we're doing is there's a poor quality of life and yet we're continuing aggressive care. So I bring that back to what matters most, for example, to the individual, and open these conversations to say, what do you want? So if it's Joe, what do you want? Tell me. Sometimes I can't say it with a partner next to them, so sometimes I will address it individually with them and then bring the partners or families in to discuss it in general with them. Difficult conversations, but you really need to have them. Again, it can happen in a doctor's office, it can happen with a caregiver even talking to Joe, for example, and asking Joe, what can I do for you? What is it that you want? How can I help you? All right, and you're really throwing that question on them. I had a case recently where an individual was failing. He wanted to go forward with aggressive care in a way, all right? His wife definitely wanted him to have aggressive care, but you could see as he transitioned, all right, from aggressive care, that he was wearing out. So I asked him, Joe, I mean, how are you doing? Are you wearing out? And he just shook his head. Shall we take a different direction? Okay? And it's a process. It doesn't happen in one conversation. Sometimes it happens in several conversations and with a variety of people. Each case is different. It's not always easy. It's sometimes very difficult. But you will run into individuals that want aggressive care up until the end of life, and you really have to address that with them also. Okay? I wouldn't want that, but they do want it. So how am I going to approach that? And that sometimes is very difficult. I might want everything done to me right now, but when I'm in that condition, all of a sudden I change my mind. Okay? Somebody that has a full code, for example, I made that full code. If we ask everyone around here, a do not resuscitate, for example, we'd probably say, yes, I want a full code or to be resuscitated. All right, well, sometimes that's carried into they're 95 years of age and dying and they still have the full code. How do we address that with the family, particularly the medical power of attorney who said, well, Joe wanted everything. Well, maybe Joe with his dementia and end-stage dementia wouldn't want that now. So it's what you wanted when you were younger and then putting it into proper perspective, what you want now under these circumstances, would it be the same? Difficult decisions, difficult discussions. There is no one answer.
Dr. Neary, on behalf of the City of Peoria, Benevilla, everybody who is watching, that was such valuable information, and we really appreciate you taking the time. I know your time is valuable, so thank you for taking the time to be here. That was fantastic.
Thank you. I appreciate it.
We're going to take a break right now. We will be back with Pam Ostrovsky. She's going to talk about understanding dementia and its impact on families. So give us 2 minutes and we'll be right back.
Acadia Pharmaceuticals is the proud sponsor of this event and a committed partner to the Parkinson's community. You may be aware of the physical symptoms related to Parkinson's disease, but did you know that around half of people living with Parkinson's may also experience hallucinations and/or delusions over the course of their disease? If you or someone you care for are living with Parkinson's disease-related hallucinations and delusions, it's important to talk to your doctor. We hope you find today's event helpful, and we look forward to engaging with you face-to-face in the future.
It may be tough to find a sense of community these days.
Am I off mute?
Can everybody hear me?
But at AARP Arizona, we're bringing the community to you.
Hi, everybody. Glad you can join.
Oh, it's so good to see you all. What are we going to learn today?
Let's get started.
Whether it's reading a good book,
I am so glad we got to read historical fiction today. It is my favorite.
learning something new,
How did that sound?
adding a spring to your step,
Do it again. 1, 2, 3, 4.
or telling someone you care about them. Connecting with others is just one click away. Visit aarp.org/near you today and find a new community tomorrow.
And welcome back. Thank you very much We're going to move on to our next guest. This is Pam Ostrovsky. She is a dementia expert, an Alzheimer's author, and CEO of Alzheimer's Consulting. Pam is the founder of Alzheimer's Family Consulting, a speaker, certified senior advisor, and certified dementia practitioner, and is certified in dementia care. She's also the author of the highly rated It's Not That Simple, Helping Families Navigate the Alzheimer's Journey, which is based on Pam's 14-year dementia and Alzheimer's journey with her parents. Welcome very much. Sorry about that blown intro there. Sometimes reading off a teleprompter is not always
it's live,
the
so
best.
now you know how all those Saturday Night Live guys feel.
I can't imagine. Yeah, I can't imagine. So thank you so much for taking the time to be here and talk to all of our. And one more time, real quick, because I don't know if we had you show your book there. Good, very much. And thank you for being here. I'm turning it over to you.
Thank you so much. I appreciate the introduction. So I want everyone to just stop for a second and close your eyes and think about a person that you love dearly. Could be a friend, a family member, and think about them slowly disappearing. And realizing that this person is changing in their personality, their ability to remember things that you both did together, and to think about what that feels like. And that's the journey that I was on for 14 years as a family member. My mother had Alzheimer's for 14 years, started out with dementia, as Alzheimer's is a type of dementia. We'll talk about that in just a minute. And my dad, in his late years, was probably 3 years of dementia. So I had both parents having difficulties in different ways. So as a family member, I felt fear, anxiety, confusion, and guilt. If you're a caregiver of someone with dementia, I can imagine and know how you feel. And so I wrote this book, It's Not That Simple, Helping Families Navigate the Alzheimer's Journey, because I had a ton of questions. And so I put them all in this book in order to provide family members, the 6.2 family members at this point in time, 6.2 million family members, who are out there with tons of questions. And we know that there's books out there, but this one's really designed for you, the dementia family member who has someone who is really struggling with either early stages, mid stages, or late stages. So we'll talk a bit about caregiving and its impact on you as a family member. So the first question is it dementia or is it Alzheimer's? The answer is it's both. So dementia is an overarching category that indicates that your loved one is struggling with 2 or more activities of daily living. You'll see that in the medical industry abbreviated to ADL, activities of daily living. And Alzheimer's is just one type of dementia. And so what that means is that there are, first of all, there's 70 different types of dementia, over 70 actually now, we've lost count. However, Alzheimer's is the one that accounts for 60 to 80% of dementias. So it's the prominent one. Most likely you're going to hear that diagnosis more often than any other. The other ones that fall in line are vascular dementia, which is number 2, and then Lewy body dementia, and then lastly frontotemporal dementia, otherwise known as FTD. And those are the top 4. So what we're going to talk about mostly today and how dementia, no matter which dementia your loved one has or has been diagnosed with, how that's going to affect you as a family member. So the things that you need to be looking for, and this is how I knew something was wrong with my mom, is anxiety. That sense of unnecessary panic over something that would be trivial. In my case, it was my dad mailing a water bill, and he was standing in line. And mom was thinking, telling me he's not going to make it. He's not going to make it. It's like, it's a water bill, mom. Don't worry about it. It's going to be fine. We'll find another post box. And so it was that panic. So watch for that behavior. Short-term memory loss. In other words, if you have somebody asking you the same question over and over and over again in a short period of time, they're not capturing what you're saying. They also can start to struggle with words, right? So now you're taking them at face value. And I have so many caregiver clients with Alzheimer's Family Consulting right now that want to talk to their loved one the way that they used to. And I feel you. I understand that you want them to be who they used to be. But if you have a loved one in a care community and they're telling you they're not feeding me, or I never leave my room, you have to talk with the care community and use them as your support team and find out what's happening, because your loved one is creating stories in their own mind as to where they are and what's happening with them. And so it's not to say that you should not listen, but get all the ends of the story and get photos and where they're showing what your loved one is doing in a memory care community. Because it's so frequently, as caregivers, we don't trust anyone. We think we're the ones who can take care of our loved one best. And in reality, I'm going to share with you some things that are not so happy, that they can be tragic to you as a caregiver, and certainly not what your loved one would want. So other things to look for, it's time to go to the doctor, is searching for words and not ever recapturing them. So we all forget who's the guy who was the main character in Top Gun. 3 in the morning, you wake up and go, Tom Cruise. And so, or Val Kilmer. And so we want to not jump to conclusions about what dementia is, but it's always good to have your loved one checked by the primary care physician. And get this, only 17% of primary care physicians do any sort of memory testing during your annual physical for a senior. Only 17%, which means that the onus is on your loved one, your parents or your spouse, and guess what? They shouldn't be in that room alone. You have to attend these kinds of doctor's appointments. It's important because, one, if their memory is failing, they're not going to remember what the doctor said. Dad and I had an argument about how much medication he was supposed to take. He was erring on too much, and I said, no, that's not right. It was less than that. And so we struggle really with where do we draw that line, especially if it's a parent, because dignity and respect, including spousal relationships, is critical on this dementia journey. You cannot treat them like children. Do not refer to them or make any reference as them being childlike. They've lived a full life. They deserve that dignity and respect. And so let's talk a bit about what that actually means in a little bit. What I want to emphasize here is there are ways, there's things called pseudo dementia, in that it's dementia symptoms, but not a dementia actual diagnosis or disease. And these factors can influence both in preventive methods as well as in helping your loved one recuperate in some way, shape, or form before they end up in a dementia state. Once you have dementia, you have dementia. But the important thing here is nutrition, hydration, and less alcohol consumption, so everything in moderation, right? And less steak and more plant foods, of course, because the leading causes, and this doesn't surprise anyone probably, but high cholesterol, heart disease, high blood pressure, diabetes, and obesity. Those 4 are contributing factors, and guess what? Those are all tied to what we put into our bodies. So it's not just about weight loss anymore, it's do you want to protect your brain? And this goes for you caregivers as well as those of your loved ones who are suffering from dementia. So exercise, get out 30 minutes a day, and mental stimulation. So it pains me when, and I noticed that Dr. Neary had a question about, well, what if your loved one isn't getting the care they need? It's really important that wherever your loved one is, whether they're at home with you or whether they get in-home care or whether they're in a care community of some sort, assisted living or memory care, that they get stimulation. They don't just stay in their room. Because if we've learned anything from 2020 is that isolation is bad for you. It's bad for your brain. And it's bad for all of our brains. It's not just your loved one with dementia. It's bad for your brain too. So stimulation is critical. Sleep, getting 8 hours of sleep, stress, hormones, believe it or not. Both male and females suffer from hormone issues that can affect dementia symptoms. And then, of course, supplements and toxins. So you want to be sure to go to your doctor and say, I want a full lab test, and I want it to include all of these things. And you can do a stress test, but most importantly, if you're getting hydrated with a lot of water, everybody take a sip of water right now. And if you're getting hydrated, you're eating primarily whole foods, and you're getting exercise, and you're getting sleep, then this journey that I'm showing you right now is less likely to happen. So sadly, and I know there's a lot on this slide, so I want you to look at the arrow and where the green starts and where the red starts, and then that box down in the corner there in the yellow. And basically, this is the journey that when I talk with senior care professionals, we estimate between 80 and 90% of families go through this journey instead of the one journey that's after this. And this is where the loved one starts to show signs of cognitive decline. And pretty much, just as Dr. Nieri said, we end up with a situation where oh, you're just getting old. Well, by the way, dementia is not a given. It is not a given. That being said, we do have a problem. 1 out of 9 people over the age of 65 have Alzheimer's and have been diagnosed with Alzheimer's. So as the baby boomer generation ages, we anticipate that number to increase. Or in other words, the ratio of people would be increased. Now, with this journey, what we typically do as family members is say, oh, it's just aging, he'll be fine living alone, or she'll be fine, or they'll be fine. But bear in mind, if you're an adult child and you leave your parents to figure it out on their own, it's a huge stressor, and it will age them. And one of them will not notice anymore because they have dementia, and the other one will be trying to hide and protect the spouse. That's what happened and happens every day with spousal relationships. Of course you want to protect the person that you've married, but here's the catch. There's a sense of guilt associated with this journey of I need to take care of my loved one. It's up to me. I can provide the best care. We're going to talk about why that may not be the case in just a moment. Now, in the bottom left-hand corner, so you'll notice that there's very little green in this arrow, and then it goes to yellow, and then it changes to orange and red. So half of it is orange and red. And that's attributed to 4 to 8 years of Alzheimer's journey, we'll call it, a path that you're going to be on after diagnosis, not before. So my mom had dementia, but was not diagnosed from 2001 to 2007. She was diagnosed and lived another 8 years with Alzheimer's and ended up going non-vocal the year after she was diagnosed, meaning that she could not speak a paragraph or have a conversation with me, ask for anything, or follow instructions, and she was in a wheelchair. So Alzheimer's had taken away her ability to walk at year 2. So you can see here that as this person is deteriorating and they're not getting any support, and we wait to the last minute, either there's a fall or they get lost in the mall, or there's a tragic event where all of a sudden you want to get them in front of a PCP, a primary care physician. Then you take them to a neurologist. They get a diagnosis. Now you're panicking because they can't live at home anymore, or your spouse can't live at home anymore. What are you going to do? Well, we're gonna call a placement agent, and we're going to find a memory care unit for mom this weekend. Well, guess what? With the volume of dementia cases being diagnosed, most of these places have wait lists now, depending on where you're going. So if you have a wait list, now what do you do, right? So they fell, they're in the hospital, they broke a bone, hospital discharges them to rehab, which rehab typically doesn't have dementia training, so now you've got that going on. And then now what are you going to do with them when they get dismissed from rehab, discharged from rehab? So this journey is not the path that you want to take. Trust me, I breaks my heart every time I work with a family and they tell me this is the story. So it creates huge amounts of stress within your own family and with your spouse, with any extended family who's involved in the situation. So it's really important that we take this journey instead. This is the healthier, happier version of the journey. Now, if you look at the arrow, there's a lot more green, a little bit of yellow, maybe a little bit more of the yellow and orange, and then the orange-red. And what this looks like is that as soon as you talk with your loved one, say they're 65, let's pick that as a number since that's what Alzheimer's Association uses for their benchmark. If they're 65, take them into their primary care physician and go with them, take notes, and have them take the mini memory state exam. That's called the MIMSA to those people who aren't familiar with it. It's a 30-question test. It asks you to do certain tasks, and it's all in the book, so you can take a look at that. There's also a MOCA test and a few other assessments that can be done. So you want to get them assessed, and you want to be sure that they understand that they're being assessed. And if they push back, I don't want to go, say, well, first of all, this is your annual exam. We need to make sure everything else is working. And then the other thing that you can do is tell them that we need a benchmark, because you're fine right now, whether they are or not. This is for their peace of mind and your peace of mind. We don't call it lying. It's called peace of mind. And so we can get a benchmark, and then we're going to have an understanding of where you are next year and the year after and the year after, because this is about brain health, just like we talk about body health. So you go to the doctor. If the doctor says you need to see a neurologist, you go to a neurologist, you get your scans. Okay, now we have a comprehensive analysis and assessment of where your brain is at today. Great. You can do that every year, and we make sure that your brain is healthy. However, if we continue to see some cognitive decline, and your loved one is having struggling a bit with repetitive statements, isn't getting the stimulation that they need, then it's time to look at other options such as in-home care. In-home care, you want to make sure that their caregivers have been through a dementia program. So there's lots of in-home care. You'll see the commercials on TV, especially this time of year, interestingly enough. But those commercials show somebody that doesn't have dementia, most likely. So we don't think about asking about dementia care. That's why when I wrote the book, I put in there questions that you need to ask in home care as well as care communities. Because caregivers, you know what? I had no idea what I was doing. As a caregiver, as an adult child, I couldn't take care of my parents. I couldn't live at their home. They couldn't live at mine. And so I didn't have a choice. I had to really move to the care community option. And Dad didn't want a stranger in his house, so no in-home care. But it never occurred to me to ask, is anybody here dementia trained? Do you know how to handle someone? Because when in the earliest stages of dementia, one of the things we caregivers don't understand is that this loved one is very angry and scared. Think about that. If you were in this situation and you were watching your world kind of crumble, and who you were and your memories and everything that makes you who you are is going away, they know it. And it's sad. So they get angry because they don't want this to happen to them. And they try to fight it. And oh, by the way, it ends up being you if you're the primary caregiver. It destroys relationships. And that's why I highly advise bringing in someone who's dementia trained into the house to provide stimulation. Your loved one will pay attention to and follow their direction much more easily than they'll pay attention to you. And so one of the biggest things that we lose in that previous slide is your relationship as a son, a daughter, or a spouse. Because once you become the caregiver, you're the caregiver. You no longer, as a person with dementia, doesn't really see you as that relative as we see them. So if you want the happier version of this, you meet with the doctor, get the benchmark early on, so let's say 65, then you move on to, okay, things are declining slowly. We need to be looking at in-home care because you want to be able to get out of the house if they're living with you or if you're a spousal relationship and you've been living together for decades. And then there's a point where now's the time to start doing research on memory care. Don't wait until a catastrophe happens. And the thing about in-home care is make sure that that home is prepared. There are professionals here in the Valley who can help you with preparing your home so that your loved one can see flooring changes, can find things more easily. They have a calming environment, not a busy environment. That will mean changes to your home. But if they move to a care community, you have to ask significant questions about training and ongoing care of your loved one and how you're going to communicate. You have to build that relationship. And that's what gets you to the box in the bottom right-hand corner of this slide, is peace of mind. You have your relationship back with your loved one who has dementia, and the stress around the family is minimal. Yes, there's going to be issues. Yes, you're going to have bridges to cross, but it's not going to be anywhere near as bad or stressful or anxiety-stricken or confusing or fearful as the first slide. So that's a really important aspect. Now, can you care for your loved one yourself? If it wasn't dementia, I would say yes. But here's the thing. Take a look at this slide. It's a much longer journey for you as a caregiver, longer duration as far as the 4 to 8 years that I mentioned for Alzheimer's, but also this person doesn't realize that they've lost who they are, so they may stand next to you and say, can we go now? Can we go now? Can we go now? Can I have breakfast? You just had breakfast. Can I have breakfast? You just had breakfast. So you keep responding the same way, which is not the way we would communicate with a loved one with dementia. So you don't have the skill set to do this. You have to learn how to work with someone with dementia. You have to be trained, preferably certified. And so the interesting thing that happens with dementia is that it takes 27 more caregiving hours per month than non-dementia. And the reason is because they're constantly present, or they're bored, they're sad, they're depressed. What do you do with that? Do you have the training to do that, to take care of this individual and all of the different emotional side effects? So again, it goes back to your skill set and whether you have the ability to keep them stimulated and engaged. They can't just sit in front of the TV and watch the news or sports. That is only going to accelerate the decline. And that's not what we typically want. We want them to have the best quality of life possible. Now, I have a couple of slides that talk about caregiving impact. This first one has to do with those of you who are employed. So say you're an adult child, 45, 50 years old, you're in the workforce, and everything in purple is the Alzheimer's caregiver, and everything in that teal color is a non-dementia caregiver. And you'll see that it goes from went in late, left early, or took time off is much higher, a 10% difference between dementia and non-dementia caregivers. Went from full or part-time work and cut down hours is the next category. Took a leave of absence, gave up work entirely, because this is a 24/7 eyes-on caregiving role. You can't leave them at home. You don't know what they're doing, and you'd like to have the home still be there. So the stories that you hear of a loved one putting their shoes in the microwave and turning it on, or putting something else, a purse, in the oven, those are very typical. They have no temporal capability, and quite frequently by mid stages they're really struggling with what objects are. That could be a closet for all they know. So signs and visuals are really important, especially when it comes to places like the closet versus the toilet room. Those things are really important. So you've got to think of all of this on top of working a full-time job. So that's why you see that this decline in caregivers. Here's the slide that scares me the most. And I think I fell under the obesity ring because you eat your way through problems if you're an emotional eater. But look at this. So we're killing ourselves taking care of people at home who have dementia. And unless you can quit your job and have someone who can pay the bills and take care of everything, if you're living alone, that's not going to happen. So how do you pay bills? How do you have a life? How do you socialize? How do you stay engaged in the world? And here you'll see non-caregivers for stroke, for the top 5 chronic conditions. They have 3.2 is their number, and dementia caregivers are at 5.2. That's the likelihood of you having an event or having the chronic condition. At 60% higher if you just kept your relationship and had a professional take care of your loved one, either in your home or in a care community, you'd be so much healthier. And then, of course, coronary disease, cardiovascular disease, diabetes, cancer, and obesity. These are not in order of gap. However, it's between 20 and 60%, depending on the chronic condition. That's a big deal. Do you think your loved one wants you to give up your life for theirs? That's what this is saying. So we need to figure this out. This is a puzzle. There's no right or wrong answers. What we need to do is work together to build a plan based on what Dr. Nieri talked about understanding your loved one's desires. You can wipe away the whole statement of, well, I promised Mom I would never put her in a home. Well, the homes that what we're referring to are from the 70s. They were skilled nursing homes. We don't put memory care people in a skilled nursing facility unless they have medical issues and dementia. So it's really important for you to dispel that for yourselves first. Do not take your loved one with you on that first visit. You go see what's available in independent living, in assisted living, and in memory care first. So it's really important that we provide the best care possible and that we don't go through the "I've got this" syndrome. Do you? Because here's the thing, it's quite possible you're actually doing more damage than good by leaving your loved one at home and having them live in their original home by themselves without it either being prepared or having 7 by 24-hour caregivers. So the thing I hear most from my clients and that I help them with is that their own relationships are suffering. Their children and their spouse are not seeing them as often. And when they do, frankly, you're kind of cranky. You're wound up because this person with dementia is struggling and you're emotionally struggling, what I call the emotional roller coaster. So the next question is, can you or will you quit your job? Do you have a way to pay your bills, or will you use their assets to do that? It's all about every situation's unique. This disease is very unique. Just because my mom lost the use of her legs and was not able to create conversations doesn't mean that your person with dementia will have the same symptoms, which makes it even more complicated, doesn't it? Because how do you know? That's why we build a plan so that we have all those triggers about what to do next. I would love for you to have the conversation earlier than later, but we'll talk about that. So it's how will you keep these poor folks safe? They don't know, and they will fight you that they do know, and that's a problem because they don't know what they don't know, and you are taking them as the caregiver, a relative, at face value. And frankly, they can't function. They're not saying what is truly reality. They're living inside their head. And so you have to ask questions differently to get those desires out. That's why, is it time to talk about living arrangements? I love this image because it's almost every adult child or spouse. I see no evil, I hear no evil, I speak no evil. Let's just ignore the conversation. As Dr. Nieri said, and as I do as well, sooner is smarter. A lot of people say, oh, well, I don't want to talk about that. Well, would you rather have, the state make the decisions? Would you rather, your loved one pass as a result of caring for you? Of course not. Let's just get this over with. It's a very straightforward conversation if you have someone guiding you. And if not, read the book because it'll walk you through it. So avoidance, this sense of denial, does not stop the progression of that. Yeah, sure, we'll just not talk about it and it won't happen. But it does. So avoidance only makes you less prepared. And it creates a chasm between you and your loved one because your loved one is scared and the thing they need most from you right then and there is love and compassion and understanding and being able to talk about what's happening to them. The more that you deny it and the less conversations you have about it, the more alone they feel. Probably not what we want as caregivers. So when do you start these conversations? As early as possible. In my opinion, when you're in your 50s, 60s, early 60s, because it's better to have a plan and not need it than to have a plan and not have one and end up panicking like that one slide showed, and losing relationships and creating stress, and life just gets really ugly quickly. So how do you know it's time to move to a living arrangement? Well, look back on your plan. What were the trigger points? What was it that made you decide, or made your loved one decide, when I can no longer X, Y, and Z, then it's time for us to move? And then how do you say it? So I have a whole chapter about how to have the conversation. What questions do you ask? Conversation starters, actual wording on how to start this. So the book is It's Not That Simple, Helping Families Navigate the Alzheimer's Journey. Pick your favorite book place to buy it. It doesn't have to be from Amazon, so it's totally up to you, but it certainly can be. And you can use the Amazon Smile program to donate to your favorite charity as well. Benefit. And then how do you handle resistance? What if they say, no, I don't want to talk about this? So depending on your relationship with your loved one, you can definitely talk to them about what's important to them. And so that they don't push back and they don't feel threatened. So often we as adults come at this, especially if we're working. Well, look, I've got to pick Susie up at 6 and I've got to get to work and I've got a text message, there's an emergency, so let's just talk about this right now. What do you want to do? And that is totally not the right conversation and method for doing that. And we typically, what I have seen and what I coach with my clients is using the right words for each situation. Words are critical when it comes to dementia, and how you speak about it, how you plan for it. So if you're not using the right words, you're getting lots of resistance, you're getting varying opinions, then you need to work with an expert, because those of us who have been through this journey have made the mistakes for you. We've learned the lessons for you, and we can help you. So my dad was independent living and my mom was assisted. Then dad was assisted and mom was memory care. Then mom had to move next door because she needed a Hoyer lift because she couldn't stand up. She couldn't follow the instructions to stand up. And dad was totally upset. So dad was in denial pretty much to, probably up until the last three years of his life, because he didn't want the love of his life to have this disease. And he said to me one day after yelling at a bunch of caregivers, he said, this isn't the way it was supposed to be. She wasn't supposed to go first. She's still alive, but she's gone. And that was so hard for him to accept. And frankly, it doesn't matter who you are. When your loved one starts to disappear, it's the worst thing on the planet, my opinion. So there are ways to work, again, this goes back to the questions for care communities, but there's ways for you to work with having two individuals of different needs. And you want to get that in writing. You want to make sure that all of this, when you have a conversation with a care community, is very clear. So then we come back to you in the emotional roller coaster. And this picture is pretty much how it feels. You've got fear, anxiety, guilt, regret, grief, sadness. And then after 3 years of not hearing my name, I walked into the recreation area, the activity space at my mom's memory care, and she said, Pammy! It was the most wonderful sound I had ever heard, and it was the last time I heard her say my name. So there's hope. And she knew me until she passed. And she would pat my knee, and we'd look through books and sing Que Sera, Sera, ironically enough, by Doris Day. And we did all of these experiences. And it was wonderful. And we had moments of joy, and we created new memories for me, not for her, but for me. And to this day, I remember stroking her hair and stroking her hand and giving her hugs and telling her when I had to go, I have to go take the dogs out. That was how we parted. I love you. I have to go take the dogs out. I'll be back. So it comes down to, yes, this is an emotional roller coaster, more so than probably any other journey. I've been through it, so I can most relate to that. So one of the things that we have the biggest gap on with caregivers and family members is communication and behaviors and how to handle them. So just quickly, I want you to look through this. There's going to be happy days and sad days. There's going to be difficult days. They're going to struggle. But we all have those, by the way. And when you speak with them, show, don't instruct. I watched a video of a caregiver who was telling their loved one to sit up, bend your knees, and that's not going to work. As someone who had a non-vocal parent with Alzheimer's, what I would have had to have done is sit on the edge of the bed and then rub my knees to show that they were bent, and then put my hands on her knees and then show that they should bend. And then they would be able to visually recognize that. So it's when in doubt, act it out. And then if it's a complicated task, so if you're ever in a memory care community, they fold up the utensils, just like the utensil rolls, and they don't know that there's utensils in there. So if you're doing a holiday event and you want everything to look pretty and you roll everything up, don't hide stuff because they can't find it. They take everything at face value. So, inevitably, you'd have to watch somebody unroll and then they would figure it out. But it's that cognitive ability and that it's unique in each individual that's so painful. Tone, never talk in a demeaning fashion. Don't talk down to them. I've heard people say, well, honey, why don't you do this? And then maybe we could look at the pictures. Do not do that. You are not demonstrating respect and dignity that this individual deserves. They've lived a full life. Speak to them as the adult that they are and understand that they can pick up on tone and emotions most. So if you get angry or frustrated, walk away because they will think that it was their fault and it will make them sad. So now you've made them sad. And that's not the end game. You could have been mad at somebody else, but you brought that to them. Always be happy, joyous, enjoy moments of joy. And just take each moment as it is. Be where your feet are. And lastly, when the end is near, and I always debate, do you want this at the beginning or at the end? But Dr. Nieri talked about it. You have to have a power of attorney, a healthcare power of attorney, advanced directives. All this stuff has to be in place before you start to see these signs of dementia. And you need to make sure that they're up to date, just as Dr. Nieri said. So if you have dementia, do you still want your DNR? Do you still want to be fully resuscitated? Big decisions that you need to work on. So know the signs when the end is near. And then most importantly, know that you've done the best that you could with the information that you had, and that you should not feel guilt or regret, just peace of mind that you did the things to provide the best care possible for your loved one with dementia. So if I brought up any questions for you, this is how you reach me. Because as a dementia expert and coach, I work with family members on everything that I've talked about and so much more. I would advise you start off with the book. Believe me, nobody makes any money off of writing books. But what I wanted to do is touch as many people's hearts as possible and give them a handbook of what this journey looks like so that you could be prepared for it and make the best decisions possible, both for you and your loved one. You can reach me at pam@itsnotthatsimple.com. Check out my website, and you can click on a contact form if you'd like to take advantage of a free 30-minute consult on Alzheimer's familyconsulting.com. So I'm on YouTube, I'm on Facebook. My Facebook page is It's Not That Simple Dementia, because that's based on the book. So if you need to reach me, I'm sure the kind folks here at Benevilla can also connect you. So thank you for listening. I hope you found this helpful.
And we'll post your information right there on the Facebook webpage as well.
Oh, thank you. I appreciate that.
So that people can contact you. Okay, so now it's time for questions. You ready?
I'm ready.
Shake that last.
Yeah,
That was a good. That was a fantastic presentation.
Thank you so much.
And it was really powerful. I'm going through something very similar to what you just discussed right now with my father, and it's.
I'm sorry.
No, and it's the more information is always better because we have a lot of the same questions. So we have a lot of the same questions. I think that our viewers do as well. So let's jump right into it and get some social media questions. And the first one that we had asked was, how do I socialize my loved one if they may not want to socialize? Maybe they're hard of hearing or they don't want to interact.
So that's a great question. And the difference is between the words socialize and engage. So a lot of times you'll hear people say, you need stimulation and engagement. That's a better way to put it than socialize, because I personally, if you put me in a room full of people, I would probably leave. I'd be the problem child. Saying, I don't really want to hang out with all these people. It's noisy and it's overwhelming. You can overstimulate someone with dementia very easily. So what you want to do is, may have, so brainhq.com has some wonderful brain exercises. And you could have your loved one sit in front of the computer and play those, depending on what stage they're at. So this is kind of a broad brush statement. But BrainHQ has lots of great games and tools and exercises to keep them busy and stimulated. Going for a walk, sensory. So more of the senses you can stimulate, the better. So visual, kinesthetic. So if they want to paint. So my mom had never picked up a paintbrush in her life. That when she first moved to a memory care community, they brought her in and they gave her a birdhouse and a bunch of paints and a paintbrush, and the activities director sat down next to her and helped her hold the paintbrush till she figured out what it was, right? And then dip and then paint. And so that's the ideal, where you're getting instructions, you're hearing someone's voice, you're getting that stimulation, visual stimulation, kinesthetic senses. Those are the ways to stimulate. So they don't have to be socialized, they don't have to hang out with people. Stimulation and engagement, getting them to do things, is most important.
Gotcha. No, that's a fantastic answer, and I think I'm on the same boat as you, where I think my wife wants to know how to socialize me as well, because game night is not my favorite thing on the face of the planet, but I do it anyway.
Yeah.
Okay, let's get to some more questions. These are fantastic. So let's see. Is it important that my loved one get diagnosed if I suspect they have dementia?
So I get this question a lot, and the reason is that we want to get them diagnosed is because you need that benchmark that I spoke about. You need to have an idea of where the brain health is at this period of time. The reason you need it is that, let's say they score 24 out of 30. Okay, that's mild cognitive impairment, borderline early dementia, early stage Alzheimer's potentially. And so you want to understand, well, what's the time frame of this journey? How fast is the disease accelerating? Or is it accelerating? So mom kind of was in a holding pattern. She got progressively worse over a 6-year period of time, but not quickly. So if she'd been diagnosed earlier on, and there are medications out there that can help with mild cognitive impairment to slow down the progression to dementia, really important, because there's no cure for Alzheimer's and there's really no treatment or medication for it. But there are medications that will slow the progression of the disease in some individuals. As I mentioned, it's very unique, and so nothing worked on my mom, but it's worth a try, I suppose. So it really does come down to understanding where you're at and then getting continued testing each year to see how it's progressing, because you have to plan financially, time-wise, personally, every way, that emotionally, for this journey. And if you don't get the benchmark, you don't know what journey you're on or how long it will be.
That makes sense. Yeah, that's a great answer. Thank you. A lot of people feel guilty about having somebody else take care of their loved one, like it should be my responsibility. What would you say to them?
Let go of the guilt. One of the biggest challenges is that if you try to do this alone, you can love your loved one better than anybody else, but you can't necessarily care for a dementia situation as well as people who are trained in the profession. It would be the equivalent of me saying, hey, let's do heart surgery on me today. You want to help me, you want to do CPR, whatever, but you don't have the skill set. And so you either change your direction of your life and get that skill set, or you learn to build a care team, which is a whole chapter in here about, you bring in home care for a certain number of hours, you make sure that you ask the right questions of that in-home care agency to make sure that they have dementia training. That helps give you peace of mind that this person understands how to handle the disease. Your loved one is happier because you remain as their son, daughter, or spouse, so you don't give up that relationship. And then if, push comes to shove, but, bottom line is, I think everybody should go tour independent, assisted, and memory care just to see what it looks like. I mean, it is like a docked luxury cruise liner. We've got music over here, we've got activities and puzzles over here, we've got cards over here. I mean, it's just, and then gourmet food. So it really does come down to find out what the landscape looks like. If you were buying a car, you would test drive a bunch of cars. Why not look at this environment and see what's available so that there's a lot less anxiety and fear about it?
How do you decide when is the right time to ask for help? Somewhere on the spectrum, on that journey, when do you say, I can't do this myself?
As soon as you start thinking it, it's time. Okay. Because ultimately, the more help you have earlier on, the better this journey is going to be for you and for your loved one. And if you wait, then you're stressed out. You saw that slide with the, how sick people get. And you don't have the opportunity to really enjoy the best quality of life with that person while they have it. So, I spent a lot of time with my mom as soon as I started noticing this disease. And she got really sad and depressed, which, oh, by the way, is that's an early stage issue, right? Because they know what's happening. And so just, if you need help, because it's hard to watch, there's no reason for you not to lean on people, build your care team, and your care team will evolve, who you rely on. You'll have different resources throughout this journey. And it's important to know who those people will be.
So a lot of times there are many decision makers involved. In my case, I've got a brother, a sister, and a mom, all taking care of my dad, and we might not agree on what that best care is. One of them thinks this is not a big deal, and another one thinks this is a crisis. How do you make a decision as a whole family or multiple siblings and that sort of thing? And
that actually is what drove me to create Alzheimer's Family Consulting. So it's about having the right conversation. I was talking with a client and she said, well, I want my life back. I want this, I want that. And my sister doesn't agree with me. She doesn't see it. And I said, well, where's your dad in this story? And what had happened is that everybody focused on their own world and didn't focus on the best thing for their loved one. And so if you can center the conversation on not, oh, well, I can't make it that day, I can't do that, or I don't think this is, I don't want him in a home, whatever the discussion and discrepancies are, it comes down to let's focus on building a plan for the next, let's call it 8 years, to figure out what are the trigger points and what's most important for dad.
I think one of the most hurtful things, and is difficult to deal with, is like a change in behavior. Maybe the person becomes more angry and even to the extent of being violent. How do you manage that?
So I struggle with this question because, so my mom was non-vocal, and if the caregivers wanted to put her dentures in and she didn't want them, she would raise her arm to block her mouth. She wasn't being vocal. She was like, I do not want this, and so this is how I can communicate it. That's not behavioral. So it depends on, so some of the other, like Lewy body and vascular dementia, do have behaviors associated with it. And just to make things even more complicated, they've now uncovered that there can be multiple types of dementia that the person's experiencing. So one wasn't enough, let's put a few more in the mix. So it's such a tragic situation to be in. And so ultimately, it's most important that you look at the person as to who they were and realize this is not who they are now. And most of those behaviors can come from not knowing you anymore, not knowing whoever's approaching them. So it's about building that familiarity and that experience so they understand who this individual is. That's why mom's situation at a memory care was perfect, because she knew the caregivers, she would pat them and she would smile, and she knew these people because it was routine. And if you just put somebody in memory care and they went straight from their home to memory care, they are going to feel disoriented for about 45 days. That's one thing that probably you don't have on the questions, but if you are a loved one, a family member, and you have vetted the memory care. Very important. You've asked the right questions. You've made sure you've observed. You've talked with family members that have loved ones there. Don't move your loved one for 45 days. This is an adjustment for everybody. And family members tend to kind of go off the rails and say, well, she's not eating, or he's not doing this, or that's not happening. And it's like, that's called adjustment. When you make that physical transition, it's an adjustment, people. It's an adjustment for you as a family member because you're not there all the time anymore. And it's an adjustment for the loved one. And that takes time. And if you don't give it time, the worst thing you can do for someone with dementia is to move them multiple times, because they're constantly disoriented. They don't know where home is. They've given up that they will ever see anything familiar again. And they're just, out there aloft, and there's no one that they can count on. And it's very sad.
Dealing with somebody that has dementia can be frustrating for the caregiver. And that also leads to guilt because you're frustrated.
Yes.
How do you, what advice do you have for someone that's kind of reaching their wit's end just in terms of frustration?
So the thing about frustration is that it means that you've spent too much time together. Mm-hmm. Because this is a frustrating disease. They're going to ask questions over and over and over again. A quick tip on that is answer differently. Because part of what's happening is that they can't recognize your response. The brain is between the amyloid plaques and tau tangles, and depending on where it's hit in the brain, there's no way for them to be able to respond to something they don't understand. So use different words, take a different approach. Now that requires creativity, and sometimes we're burnt out. We've just worked a 60-hour work week, and the last thing we feel like doing is having a conversation without being frustrated. And so to avoid the frustration, the best thing to do is to bring in help, right? So bring in an in-home caregiver to handle between 4 and 7 p.m. so that you kind of can come home from work and kind of do your thing and take a breath. And so having me time is really important to avoid that frustration. And then the other thing, it's about if you have a care team or you have your loved one in assisted or memory care, they're going to have their life again and you're going to have yours. And when you come together, it's a much happier, better experience because they didn't live with you your entire life. Think of that. If your dad had lived there with you all of his life, he probably would have been annoying and frustrating as well. But because you lived in separate places, you restored that relationship.
Yeah.
Yeah. So same thing with this.
It's just all of it is fantastic advice, and it was really great to hear. Pam, thank you so much for joining us. One more time, it's not simple.
Not that simple.
Oh, it's not. I'm so sorry.
Yeah, it's okay.
Eyesight. I'm losing my eyesight here. It's not that simple. Thank you.
That's a different problem.
Yeah.
Helping families navigate the Alzheimer's journey. Yes. And it was funny because Dr. Nieri was saying, it's not easy. It's not easy. And I'm like, no, it's not that simple.
I love that. Thank you again for joining us.
It was my pleasure. Thank you for having me.
Benevilla, City of Peoria, we just want to say thanks for coming out here.
It's my pleasure.
We're going to take another quick break, and we're going to come back with Taylor Gurney from Benevilla, and she's going to talk a little bit about Benevilla and what they do, and then we will have our very last guest of the day, and that's going to be Dr. Etri. So we will see you back here in just 2 minutes. Stay tuned. Thank you.
Acadia Pharmaceuticals is the proud sponsor of this event and a committed partner to the Parkinson's community. You may be aware of the physical symptoms related to Parkinson's disease, but did you know that around half of people living with Parkinson's may also experience hallucinations and/or delusions over the course of their disease? If you or someone you care for are living with Parkinson's disease-related hallucinations and delusions, it's important to talk to your doctor. We hope you find today's event helpful, and we look forward to engaging with you face-to-face in the future.
It may be tough to find a sense of community these days.
Am I off mute?
Can everybody hear me?
But at AARP Arizona, we're bringing the community to you.
Hi, everybody. Glad you could join.
Oh, it's so good to see you all. What are we going to learn today?
Let's get started.
Whether it's reading a good book,
I am so glad we got to read historical fiction today. It is my favorite.
Learning something new.
How did that sound?
Adding a spring to your step.
Do it again. 1, 2, 3, 4.
Or telling someone you care about them. Connecting with others is just one click away. Visit aarp.org/near you today and find a new community tomorrow.
And welcome back. We're going to be with Dr. Attray in about 20 minutes, who's going to talk about new methods of treatment for Alzheimer's. In the meantime, we are here with Taylor Gurney from Benevilla. Taylor, thank you so much for giving us your time.
Yeah, no problem.
So for those of our audience that don't necessarily know what Benevilla is, can you just give me an overview of what Benevilla is and what they do?
Yeah, so actually this year we're celebrating our 40-year anniversary. So Benevilla has been around since 1981. It started as a group of people that came together and saw a need, especially in the West Valley, for our older adults. And it kind of stemmed from there. We have many different programs where we're serving adults that are in their home and trying to keep them independent as long as possible. So that includes, we have free home services. So all of our volunteers that we have, and right now we have over 200, are helping community members stay at home by helping them with grocery shopping, helping them with assisted transportation to medical appointments, just friendly visitors, phone pals, kind of helping with that isolation. They do light handyman services and then business assistance as well. So even during COVID, this was a huge service that we could provide, especially the grocery shopping and the medical appointments where people weren't necessarily wanting to go out in the community. So we've been doing that since the beginning. We also have 4 different Life Enrichment Day programs. So those are day programs open Monday through Friday, about 8 to 5, where caregivers can bring their loved ones with different diagnosis, if it's dementia, Parkinson's, stroke survivors, that kind of thing. And they can come there and get socialization, daytime programming, creative aging, all of that kind of stuff. So we have 4 of those different programs. We also serve adults with disabilities as well. So we also are here to support the caregiver, and that's hence this whole event that we have today. We have free caregiver support groups, life coaching, and then just a whole library of resources that we can provide the community.
So who should reach out to you? Should it be, I have some concerns about my dad, or should it be my dad is looking for a way to socialize? Who do you service?
We service everybody. So it's really, we are from 6 weeks old to kind of end of life, because we do have a preschool childcare on our campus as well. That starts 6 weeks, it's called Word Seas, and 6 weeks to 5 years old. So we do an intergenerational program. We really are here to enrich the lives of the whole entire community. So we have a lot of caregivers that reach out because they are looking for those resources and that support. And that's usually kind of the first step, because they're looking for that support for their family member. But like I said, we are here to support everybody in the community, really. So.
That's great.
Yeah.
You mentioned you have volunteers, and as soon as you said light handyman services, I thought, hey, there's something I can actually help with.
Yeah.
For those people that do want to help, how would they get involved?
Yeah, so you can apply online at benevilla.org, and there's just a volunteer application on there. You can kind of specify what you're interested in, like so if you were interested in the light handyman services or helping somebody grocery shop, that's a great way to apply. You can also call us and talk to our volunteer coordinator, but we are in dire need of volunteers right now. We have so many people in the community that need our services. So,
how has the last year and COVID been different for you guys, and how are you coping?
Yes, so luckily we kept our preschool and childcare open the whole time, and we were able to support essential workers, and because they have their kids and they have to go out and work, so we want to make sure we stayed open for them. Our day care programs actually did shut down for a little bit, but now we're back open and we have all of the stricter policies and everything like that. But we did see there's a huge need for caregivers to have that kind of time off and have that respite care. So we're making sure that we're staying open and being able to serve everybody. The volunteer workforce did go down, of course, and that was just because people were being careful and staying home and all that kind of stuff. But again, as that happened, that community that needed that support grew as well. So right now we are actively recruiting volunteers, but again, like I said, we have a huge need for it. But we are open and we are here to serve the community now, and like I said, we've seen a huge need for it, especially because of COVID.
So you're here at the City of Peoria today, and we are partnering,
Yes.
but this is not our only partnership. Can you talk a little bit about other things you partner with the City of Peoria on?
Yeah, so we're actually in your Peoria Resource Center, our family resource center that we have that actually serves parents with children from 1 to 5. They are there and they are active members, and the community can come in and speak with them if they need any family support. We also used to have a space in the Peoria Library for our home services, but if you go there, you can find all of our resources as well. But yeah, we're just so happy to partner with you guys, and this is our, I think, 4th Caregiver Connect we've done with you guys, and the broadcast is amazing, and we're so lucky to be able to continue to reach all these people.
And the Peoria Community Center and the Resource Center, which is within our Community Resource Center, is located in downtown Peoria. It's on Jefferson Avenue and 83rd. And we have so many resources available to everybody in the city. We call it Peoria Support, and our Peoria Support team helps everybody from the young kids, veterans, helps people get jobs, helps people obviously with senior care. So if you have a need and you don't know where to start, the City of Peoria Resource Center and Peoria Support is such an amazing site, and you can find Benevilla there, and you can find so many other sources for help, rent help, electricity help during these times. That's just such a great place to start. And I think you can find them online at www.peoriaz.gov/Peoria Support. So check that out to find out all sorts of information, not just Benevilla, but any help that you might need. So I wanted to get a plug in for
awesome.
for Peoria Support really quickly. What else would you like people to know about Benevilla? Is there anything that we don't know, or anything that you'd like people to know? How can they find out about you?
Yeah, so all of our information is online at benevilla.org. You can also call 623-584-4999, and you'll speak to our wonderful receptionist. They can help you and guide you in any way that you need. We also, today is Giving Tuesday, which is a National Giving Day. So of course, that's a great way to support the organization. We also have an anonymous donor that is matching all of the donations up to $10,000. So we're hoping to reach that goal, and it's just, again, a great way to support such a needed organization in the community. So, and then again, like we said, if anybody is interested, please come and volunteer with us. It is such a great organization and so many different opportunities for people. So I also do want to say thank you to our event series sponsors. We have AARP Phoenix and then Acadia Pharmaceuticals. So thank you very much to you guys for sponsoring the Caregiver Connect, and then thank you as well.
Oh, yeah, of course. The City of Peoria loves to do this. We're live on our Facebook page right now. We are live on Peoria Channel 11, and we are taking questions from members of the public. So if you have a question for our next guest, if you have a question for our earlier guest, post them there. And also, if you missed this, maybe you're watching it on our Facebook page and it's not live anymore, just post those questions right there, and we'll make sure they get to whoever the right person is. So you said Benevilla has been open for 40 years. Do you primarily serve the entire valley, the West Valley? How does that work?
We are solely in the West Valley. Okay. We pretty much the farthest we go out is Peoria, Glendale. Okay. We do have a Life Enrichment Day program right down the street here in Peoria, but really Sun City West, Surprise, that whole West Valley area.
And you mentioned you work with adults with disabilities. What programs do you have for them?
Yeah, so we have a program called Helping Partners program, and again, they serve adults with disabilities, and they also have something what's called Group Supported Employment, where they provide them job training and job coaching, and they get to go out and work in the community. We have a partnership with Chick-fil-A right now where they get to work there, earn a paycheck, and it's all through the Benevilla program. So they get to come and enjoy each other's company and learn great life skills and have that socialization as well. So
that's great. Fantastic. Yeah. And again, to promote the City of Peoria, our adult day program that we have as well, I got to cover an art class the other day, and we made a video, and you can find the video on YouTube, but we made a video about our adult program and the art class. And just the small things. We talk about socialization, the small things like having an art class, and they all meet via Zoom because now we're in the COVID world. So instead of going to an art class, they all meet via Zoom, and I've gotten to see some of those Zoom classes, and that socialization, that skill building, it's so vitally important, and it is for our senior.
It's very special, yeah.
Do you guys have any other classes or social things that you offer?
Yeah, so we actually have a brand new program that we're starting at Benevilla. It's called Benefitness, and it's on our Surprise campus, and it's actually going to be a restorative gym that we are opening. It's kind of in the works right now. It's under construction, but they don't have a concrete date of when they're opening, but sometime in 2022. And it's actually going to be a gym that serves those with movement disorders, and we have something called Rock Steady Boxing that is specific for Parkinson's. And it's going to be a whole boxing studio, small group training classes, all adaptive equipment, that kind of thing. So something very special that's coming to the West Valley.
Cool.
That we're excited to introduce coming in the new year. So
bring one of those to Peoria too.
I know, how fun, right?
That sounds fantastic.
Yes, but doing good things over here.
Well, yeah, and it does sound like you're doing good things, and that's one of the reasons why we kind of invite you in and have this partnership, is because of the amazing work that you do in the West Valley. So and Peoria support is such an important thing to us, to help out to the community. You mentioned fitness and exercise. That's so important to our senior communities as a whole. We have our silver sneakers. Do you have any other programs for seniors in fitness, or do you do anything else with that?
Yeah, so that's probably going to be our biggest adventures, the Benefitness, opening that. But just within our programs, we are doing daily exercise. They have Tai Chi, yoga, all these instructors that come in, and we are welcoming them back now, which is great. It's not just virtual. So they're out there on the patio doing it. We involve the children. They have yoga classes all together. So yeah, it is something very special, but also really important.
Did you guys end up doing any virtual stuff during COVID, like virtual yoga classes? We did as well.
Yeah, and right now we are still offering virtual tours of our programs. So those families that can't make it in or don't feel comfortable, we can provide a virtual tour so they can see the program before they bring their loved one in. So we're still offering that, and it's been nice to have those different options, COVID or not. So it's been great. The virtual can only go so far, though. We want people in person, and we want them enjoying their time together. So.
Do you guys have a physical location, and if so, where's it at?
Yes, so we have a location in Surprise. It's off of Greasewood and Bell, and then we also have a building in Sun City, and then also here in Peoria. So
excellent.
We're all over.
Very good. Well, again, Taylor, thank you for giving us your time.
Thank
you for coming to fill in and talk to us here for a few minutes. We are just a few minutes away from having our next guest, Dr. Attree, who is going to talk all about a new era of targeted treatments for Alzheimer's disease, our progress and challenges. So we really look forward to that presentation. We're going to take a few-minute break, and we will be back just in a few minutes with our very next guest. And thank you for staying tuned, and thank you for watching.
Acadia Pharmaceuticals is the proud sponsor of this event and a committed partner to the Parkinson's community. You may be aware of the physical symptoms related to Parkinson's disease, but did you know that around half of people living with Parkinson's may also experience hallucinations and/or delusions over the course of their disease? If you or someone you care for are living with Parkinson's disease-related hallucinations and delusions, it's important to talk to your doctor. We hope you find today's event helpful, and we look forward to engaging with you face-to-face in the future.
It may be tough to find a sense of community these days.
Am I off mute?
Can everybody hear me?
But at AARP Arizona, we're bringing the community to you.
Hi, everybody. Glad you could join.
Oh, it's so good to see you all. What are we going to learn today?
Let's get started.
Whether it's reading a good book.
I am so glad we got to read historical fiction today. It is my favorite.
Learning something new.
that sound?
3,
Adding a spring to your
4.
step.
Do it again. 1, 2, 3, 4.
Or telling someone you care about them. Connecting with others is just one click away. Visit aarp.org/near you today and find a new community tomorrow.
And welcome back to the Caregiver Connect by Benevilla and the City of Peoria. Thank you for your patience and bearing with us there. We are ready for our next guest. We have Dr. Attree here. Dr. Attree is a cognitive and behavioral neurologist who earned his undergraduate and master degree at doctoral degrees at UCLA and Harvard Medical School, and his medical degree at San Francisco. He is the medical director of Banner Sun Health Research Institute in Sun City, Arizona. Dr. Attree sees the Banner Sun Health Research Institute as a regional and national hub for dementia education and clinical best practices. Dr. Attree, thank you so much for joining us today, and we look forward to your information.
Well, thank you for having me. Yes, I really appreciate it. So as mentioned, I take care of patients and families with early and different kinds of impairment, oftentimes in the spectrum of Alzheimer's disease. But there's also cousins of Alzheimer's disease that cause dementia. And it's really exciting to talk to you today about a new era. Specifically today, we're going to focus on Alzheimer's disease treatments and the opportunities and challenges that we have going forward. I always like to begin my talks to ground everybody with this quote that I really like. It goes like this: human beings are members of a whole, in creation of one essence and soul. If one member is afflicted with pain, other members uneasy will remain. If you have no sympathy for human pain, the name of human you cannot retain. And this is as true now as it was 850 years ago in ancient Persia, Iran. And I bring this up because I'll be telling you about proteins that go wrong and become sticky in the brain. And that's really the cause of many of the neurodegenerative dementias. And Alzheimer's is one of them. It's the most common one. And it's caused by 2 different proteins. And now we can actually look at these proteins while people are alive. So we can actually make diagnoses while people are alive. And we do these in various ways, including with PET scans, for example. What it really comes down to, though, and this quote actually really epitomizes, is it's about people. It's about the person who's affected and the whole community that really is also affected by the illness and the disease. So with that, what I want to do is to give you a little bit of a roadmap for today. I'll talk about what's dementia and what's Alzheimer's disease. That's a very common question. What's the difference between them? A little bit about the scope of the problem and how really we're entering a phase where this is a very, very pressing problem, both for individuals and from a public health standpoint. And then talk about these proteins and the cause of Alzheimer's disease and how we can actually now detect it during life, years before actually people can show symptoms, and where that's taking us with really treatments, and what are opportunities for treatment for individuals who have problems now, and for those who may have the disease but want to in many ways prevent it or delay it. And then I'll end with some bonus sort of recommendations about brain health and prevention. So as far as dementia goes, what is dementia? Well, dementia is not a specific disease, it's a condition. It's an overall term we use for changes in cognitive functions, memory, thinking, language, executive function, things like that, that are really a significant change from a previous level, and they're severe enough now to interfere with independence in doing things like activities of daily living or behavior and social function. So and it's really it's a subjective call, because one morning one doesn't wake up if one has a neurodegenerative dementia like Alzheimer's disease or condition with dementia. It's really years of changes, some small, some bigger, and then ultimately at some point, if this is noticed and it's interfering with daily function, then it may meet the threshold of what we call dementia. But dementia itself can be caused by multiple conditions. When individuals are older, Alzheimer's disease is one of them, but vascular changes in the brain, other proteins that become sticky in the brain, proteins related, for example, to Parkinson's disease, or other proteins that we are discovering. And commonly, what we find that individuals who are in their 80s or older generally don't have one of these sticky proteins, they have many. But one of the main messages I want to relay today is that Alzheimer's disease and related conditions like it, even though they're prevalent when individuals are older in life, they really are neurodegenerative diseases. So they have causes that we can determine now while people are alive, particularly for Alzheimer's disease. And they can actually be managed and diagnosed meaningfully. We don't have a cure, but they can actually be diagnosed during life and meaningfully managed. And so it's really important not to confound something that's common with something that's normal. So it's not normal to have dementia when you're older. It's not normal to have Alzheimer's disease. And yet, unfortunately, there is this misperception when individuals have symptoms to ascribe it or misattribute it to normal aging. That happens to all of us, including to actually clinicians who still have a perception that maybe this is part of aging when it's not. So what's the scope of the problem? Well, the scope of the problem is increasing, unfortunately. So when you look at all around the world, not just in the US, you look at Europe, you look at Asia, you look at Africa, and the numbers are in the millions and tens of millions and increasing. And over the next 20 to 30 years, by the middle of the century, in all different areas of the world, there's going to be a doubling, tripling, or more of individuals. And that has a lot to do with actually individuals living longer. And it's a very costly disease, so direct costs around $300 billion with a B dollars a year. And these are just direct costs that we can measure in the system. Unfortunately, along with that, there's caregiving costs and a lot of costs that are borne by families, which are not accounted for in our accounting system, in the healthcare system. Alzheimer's disease is a major cause of dementia. It's actually the 6th leading cause of mortality, of dying in the US. And it's the 5th in the whole world. And these numbers have been skyrocketing over the last 10 to 20 years. So all the other leading causes of mortality are going down. Alzheimer's is going up by about 150% or more. For example, deaths from heart disease have gone down by 9% in the last approximately 20 years. For Alzheimer's disease, they've gone up by about almost 150%. And Alzheimer's disease actually kills more individuals than persons with breast cancer and prostate cancer combined. So it's really a big issue. And it's not just individuals who are older, who are in their 80s or 90s. Individuals who are young, actually, in their 50s and 60s, estimates range anywhere from 200 to 400,000 individuals in the US actually have Alzheimer's disease impairments related to it. And so this can be a disease that affects individuals who are even younger. Some more statistics, 1 out of 3 seniors will die with Alzheimer's disease or another dementia. And so when it comes to this and the collective effect it has on society, really the answer to caring for individuals for treatments isn't going to come from a pharmaceutical company or government. It really requires this collaboration. And I think what I'm trying to, hopefully by the end of this the talk today, you'll appreciate that we've come a long way and we have things in our arsenal now to detect it. And I think in the next 10 to 20 years, we're going to do a lot better in being able to slowing down this process. So just a little bit of history, back in 1901, a young lady, at the time 51 years old, was admitted to a psychiatric hospital. And Professor Alois Alzheimer, who was a psychiatrist at the time, examined this lady. And she was there because she was very agitated. She actually was very aggressive and had really behavioral changes. And that's one of the things that goes along sometimes with Alzheimer's disease in some individuals. But what Professor Alzheimer's noticed was that she was incredibly forgetful, and that she was forgetting things within minutes. And at that time, they didn't have MRIs or PET scans or the tests that we have now. And they had this new method of looking at the brain. So when she died 5 years later, at only age 56 years old, he examined the brain and noticed these things that he described, these plaques and tangles, which we'll talk about a little bit more. They called this Alzheimer's disease, and they called it pre-senile dementia. So just in the term itself, there was a bit of ageism, because the thought was senile. So as you got older, you had dementia. And the thought was for the next even 50, 60, or 70 years is that senile dementia, as people getting older, they lose their abilities to function and such due to what they call hardening of the arteries. And it wasn't until really the 70s when they were doing more studies, and they realized that really this thing that they thought really caused, was rare, was really a major cause of dementia. So fast forward for the next several years, these proteins were actually identified in these plaques and tangles. They were identified as a protein called amyloid, which caused the plaques in the brain, and another protein called tau that caused the tangles in the brain. And then we started really looking at some of the genetics and some of the risk factors, and some of the first treatments were based on different thoughts, not based on the clearing of these proteins, not based on making these proteins less toxic, but at the downstream effects at the neurochemicals. So that's what basically brought us the current generation of Alzheimer's treatments, okay? And for many, many years, if you went to medical school or you were in training, in nursing, et cetera, you were told that, you know, during life you could think that somebody had Alzheimer's disease, but you really couldn't prove it because you needed the brain. And that's one thing that's really changed recently. And we can now definitively say when an individual actually has Alzheimer's in the brain, and during life, because of these things that I'll tell you, called biomarkers. And these are things that we can measure and give us really, really high certainty that the individual has the disease in the brain. So, so more recently, you've probably read news reports that there's a new drug that has been approved through what we call an accelerated pathway. I'll explain that a little bit more later, that clears some of these proteins from the brain. And that's one of our forays now into being able to take a disease during life. We don't need brain tissue anymore to actually prove it, and start to look at really the biological basis and try to, in many ways, as soon as possible, change the trajectory in the course. So let me explain a little bit more to you about what causes Alzheimer's disease. So Alzheimer's disease is defined by, as I mentioned to you, these amyloid protein plaques and these neurofibrillary tangles. And over the years, what we've learned is the plaques are made up of these proteins from amyloid beta protein. It's a protein that probably involves some, has some connection, not just with learning, but also really with what we call synaptic activity. So synapses are these trillions and trillions of small connections between brain cells. They give us our computational power, basically. And this amyloid protein sits in the membrane of cells, kind of like this, and it can be cut in certain ways. And a certain cut that gives you this 42 long protein, amino acid protein, is more toxic. And it sticks together over time and becomes really toxic to these synapses, and then starts another runaway process, ultimately causing inflammation and neurofibrillary tangles. And the tangles are made up from this protein called tau. They're inside the neurons, and they really stabilize, almost like a scaffolding, the neurons themselves. And once this amyloid protein causes toxicity to cause inflammation and a change in these tau proteins, the tau proteins can then go on and spread from cell to cell and cause more damage. So the way that I kind of think about it in a simplistic way, you can imagine having this beautiful mansion, this beautiful house, let's say that's your brain, and you have people in it, let's say these are synapses or the nerve cells, and amyloid protein is like having toxic kindling. So for years and years, imagine being in this beautiful mansion, working here, and you're having amyloid deposit. It's making some of the people sick. It's making some of the structure kind of peel off, but you don't have a fire yet. And ultimately, at some point, when the balance tips between what we call resilience factors and vulnerability factors, suddenly that fire starts. And there's two kinds of fires that kind of start with this amyloid. One is inflammation in the brain, which is really toxic and spreads. And the other one is a fire related to these tau proteins. So now, boom, a fire started. It's going from place to place. It's damaging not just this beautiful mansion, but also the people in it. And there's a secondary process. So if you take away this amyloid protein, you may be able to suck some kindling out of this fire that's going on in the brain, but you may not be able to stop it. And so you probably can see where I'm going with this. Ultimately, you need to address multiple mechanisms, probably the amyloid protein, this is the kindling, the fire that's spreading between inflammation and these tangles. And that's where we're at right now. Before, we couldn't measure these things. And now we're coming to an era where during life we can start measuring these things. And that's really important to appreciate. So based on this understanding, which most of it really has happened in the last 10, 15 years, we have an understanding that the disease itself, these proteins getting sticky and causing plaques, can start really about 20, 25 years before individuals show their symptoms. So they start coming up, and then anywhere between 10 to 15 years before or more, then the tangles start coming together. And then up to maybe 5 to 10 years before, we can actually start measuring changes in activity in the brain using, looking at how glucose is being used in the brain, thinning and losing structure in the brain. So again, this is years before people are coming and showing symptoms of forgetfulness or difficulty finding words or being less efficient in what they're doing. And so that's really, really critical, because that's an early period where we can actually intervene. And prevention is always better than waiting until the house is mostly burnt down and then trying to putting some of the fires out. So I'll talk about the risk factors more. Age is still a major one. There's some rare conditions, very, very rare, where individuals have genes that they pass from one generation to another that are really causing this. But it's a complex disease, so it involves multiple environmental factors and genetic factors and susceptibilities. We know one of the major things is obviously family history. You have a family history that increases your risk. Anything that's really bad for brain circulation in the blood vessels is a risk factor. So high cholesterol, diabetes, smoking, high blood pressure, and a number of other things. But ultimately, what we find is that maybe in younger people that have these unusual and rare mutations that cause Alzheimer's disease, it's one condition then causes, again, a fire to spread. But by the time one is 80 or more, chances are that these proteins, as they're gumming up the works in the brain themselves, they're causing other proteins to not be cleared in the brain either. So what that means is that our work isn't done. There's aging mechanisms, there are mechanisms related to Alzheimer's disease, and then that can also mean that the machinery inside cells in the brain can go wrong with energy metabolism, with clearing of other toxic forms of proteins, which are then become susceptible to. So in the future, we're going to have to address each of these buckets and hopefully doing it earlier. Now, What are the symptoms of Alzheimer's disease? Well, we know there's cognitive systems in memory, thinking, language, problem solving, ultimately affects daily function, and then there's behavioral symptoms. So there could be loss of initiative, depressive symptoms, irritability, agitation, and those are things we can also address. So what we do now in research, and it's coming into clinical trials and also in the clinic, is we can then classify individuals as having Alzheimer's disease before having symptoms, okay? So you can be in the Alzheimer's continuum by having amyloid protein in the brain or having tangles in the brain, these neurofibrillary tangles, and if they've caused neurodegeneration, so loss of nerve cells or things like that, we can measure those too. So we call this the ATN classification, and based on that, in the future, we'll be able to attack each one of these parts and classify in other contributions, maybe vascular contributions or neuroinflammatory contributions, and have drugs that affect each one of those things. So going back to the biomarkers, how do we measure these things now in the brain? Well, we have a few different methods that are available clinically. One is through measuring it through spinal fluid. So we've heard about a lumbar puncture. It's an easy process. It's actually done for most diagnoses in Europe. We do it less here, but folks like us are used to doing it. You can actually measure these proteins, the amyloid and the tangles from the spinal fluid. There's ways of having what we call PET scans also that can measure the amyloid protein and the tau protein. They're very expensive and oftentimes now really covered through research trials for the most part, but they are available, even clinically, but expensive. So where are we going with that? We're going to blood. And right now, there's ways that through blood and research, we can have a pretty high likelihood of getting blood and having that correlate with what we see in the spinal fluid and the PET scans. So in the future, 3, 4, 5, 6 years from now, there are going to be blood tests for Alzheimer's disease. Are they going to be definitive? No. Chances are at first, that we need to validate them. And for individuals who have high levels of that, they may go on to get spinal fluid, for example, or PET scans. But that's really, really important because it means that we can influence these proteins before individual has symptoms. So think about the 70s and 80s, the whole understanding that we had through cholesterol, for example, good cholesterol, bad cholesterol, or blood pressure. Now those are risk factors. They're risk factors for what? Heart disease, heart failure, right? Stroke. And if you go back, what did they do? There was arguments about which is the good cholesterol, what is the bad cholesterol, how much blood pressure, which one, the high one or the low one, the top or the lower number. And through years of doing prevention trials, you realize that, you know what, if you give people, individuals, medicines to lower some of these things, you're going to stop something in the future, like a heart attack or a stroke. And that's where we are with Alzheimer's disease now. So let me switch now to the treatments. The treatments that we have to be personalized, and it's the first step of giving somebody care is actually to recognize there's a problem. So the first step is really detection, accurate detection, appropriate diagnosis, and disclosure to patients and families. And unfortunately, what the data shows is individuals often have symptoms that go on for 3 to 5 to 7 years. And some of them actually go to clinicians and report them, but they're not tested. It's misattributed to something else. So for example, they recognize a behavioral change or a mood change or a sleep change or irritability, and they put it down to, for example, depression. Really, in many cases, if you're older and you're having some of these difficulties, it means probably neurochemicals are changing. And neurodegenerative conditions are really on the table to be looked at then. So I guess the first step is really this getting the accurate diagnosis and detection, which is important. The second kind of principle is understanding what it means. What does the disease mean? What does it mean for changing environment and lifestyles? The third principle is actually taking bad medications away. Not giving medications, but actually taking bad medications away. A lot of individuals are on medicines. When you add them together, they're actually not really good for the brain. And so that's important. And then getting on the medicines that we have for Alzheimer's disease. And the two kinds that we've had for a while now work on two different brain chemical systems. What do? They support basically better and more efficient functioning of neurons in the brain and systems in the brain. Do they stop working? No. Our data shows that they don't stop working. And I think that's another myth, for example. It's just that individuals don't need the highest doses to start with, and as time goes on, they need more and more doses. But what data has shown is that the sooner you start the medicines, the better. People who started later don't catch up. And even when individuals are progressing, where clinicians may think that the drugs are not working, there have been studies done to show that if you randomly take people off, they do worse than others. They end up having more functional or behavioral decline. So that's one type. So basically the hope is you get diagnosed, you get on these medicines, and you have either improvement in some symptoms or stability for 6 months, 1 year, or more. And that happens to about 70 to 80% of individuals if you follow them. But ultimately, people will go down. There's aging and the disease progresses. Again, the drug doesn't stop working. The new approaches are removing some of these amyloid proteins from the brain. And what the thought there is that you're not going to get a bump up, but instead of going down like this over time, it kind of slows down the slope this way. So you can see once you start building these two things together, a number of things together, you can probably put people on a different course and slow down the decline. And that's really the promise of this new generation of drugs that are under consideration now by the FDA, and one of them was just recently approved that I'll tell you about. And that drug is called aducanumab, and I'll tell you sort of the principles behind it. Before I do that, though, I want to tell you more about the pipeline. So the drugs now in the pipeline for Alzheimer's disease are not just looking at amyloid and tau. Traditionally, there's been a lot of focus on the amyloid protein. Now we're finally getting to a point where we can measure it and we can remove it. I'll tell you more about that. The next stop is looking at the tangles and inflammation. And there's a number of drugs that are being also looked at that involve things like behavior. And so currently 126 agents are at some stage of development for Alzheimer's disease, and many of them are in phase 3, where we're really looking at showing in randomized studies whether they work and how much in their safety. So let's go to this new drug that was approved in June, and think about what it does and what it doesn't do. It's a what we call a second generation drug. The first generations of these type of drugs, which are monoclonal antibodies nowadays, I think we've heard about those through COVID. Basically, what they try to do is try to have give antibodies basically that recognize some of these proteins in the brain, like amyloid protein, and then remove them. So they're second generation because the study started about 15, 20 years ago with the first generation drugs. At that time, what we learned is that if we give it in the stages of more advanced dementia, it wasn't going to work. B, we learned that we had to have doses that were high enough, and it's taken us about 10 years to get there. And then 3, we had to be able to show that people who went into these studies actually had enough plaques in the brain. And remember, we didn't have ways to measure that 20 years ago as much. So it's a second generation drug that now has been shown in 2 studies that it can very clearly remove amyloid from the brain. And some of the data that's emerging also shows that not only is it removing some of this plaque from the brain, kind of rinsing your brain of these plaques that have been accumulating for, as I mentioned to you, 20 or 30 years. As it's doing that, we're getting hints, and this is really, really new research that has been presented just recently. It's doing something to the tangles also. And it's doing something to other things that are related to neurodegeneration. So based on that, the FDA gave this drug accelerated approval. Not because it actually has been proven that it slows down clinical decline. Some of the early studies and the 2 studies that were done, there were some issues, and it was basically passed based on a reasonable assumption that down the line, it could actually slow down decline. How much? On average, about 20 to 30%. So now that 20 to 30% may be more for some, it may be less for others. And it also did that not in a vacuum, because there are other classes of drugs that are like it, that are akin to it, that are also rinsing the brain, and they're showing about the same effects. So about a year and a half down the line, getting some of your brain sort of rinsed out with these medicines seems to be translating, at least in clinical research trials, to the equivalent of 20 to 30% slowing. So it's not like you're going to get these drugs now and you're going to go back the way you were 20 years ago. But you can see where I'm going with this. If you then go earlier, then the chance is, how much earlier do you have to go, and how much do you have to take out, and who gets to benefit the most? Because even if you're in the earlier stages and you've been diagnosed, you may have 10, 15 years of life left in some cases, if it's early enough. And at 20 to 30%, if it sustains, could actually mean 2, 3, 4 years of higher functioning. So that's I guess the good news. The bad news is we're still learning how to actually apply this in clinical practice. And some individuals, anywhere from 20 to 40%, as these plaques are being removed, they get kind of stuck right at the blood vessels that are leaky, and they cause some inflammation. So about 3/4 of the individuals who get this inflammatory response, they don't have any symptoms at all. That's only seen on MRIs. But in some cases, the other 24%, they can actually have symptoms, and rarely actually it could actually cause them to have to end up in a hospital. So so this is really where this new era comes in. Finally, we're measuring things. We're able to at least take one of these proteins out of the brain, but we don't know in who and how much. And we're still figuring out the monitoring and safety part of it. And what also has been shown is that it's really not something that can be done in the dementia, in the later and more advanced dementia stages. You have to come in earlier for that. The downside, again, as I mentioned, is in some cases, like this drug aducanumab, it's a monthly infusion. You have to have monitoring MRIs, and in some cases, you can get leakiness and inflammation, and actually some bruising and a little bit of bleeding. So it has to be done in the right patient. It has to be monitored the right way by the right people. So we've got years of learning to do there. And as we're doing that, other drugs are coming along to look at the tangles and the inflammation. So what we want to do, just like HIV, we want to diagnose early and hit it with multiple mechanisms. And when that was done, right, they've taken a drug that used to be uniformly fatal and it made it into something chronic and more manageable. And this is why it's really, really important that intervention happen before there's widespread damage in the brain. By the time people have really showing major symptoms, the organ in the brain is failing. And it's a one-way street. But delaying even the dementia stages by 5 years would actually decrease projected Medicare costs by about 50%. And we don't, in any other disease state, we know now, in cancer, stroke, heart disease, et cetera, HIV, diabetes, osteoporosis, we don't wait. In cancer, you don't wait to say, oh gosh, well, I've seen this nodule. I'm going to wait for it to spread everywhere and metastasize, then I'm going to start treating you. No, we want to go really early on and prevent before the organ fails. And this is why the promise is for these new class of drugs, even though we have to figure them out, is important. Because, for example, multiple sclerosis, back in the early 90s, when the first drugs came out, they were based on the biomarker. And I remember being in medical school and hearing that, well, those drugs aren't proven. If they are, they may affect clinical decline a little bit. They were approved based on a biomarker, which meant what? For multiple sclerosis, they looked at plaque load in the brain, different kind of plaque, and they gave these drugs. They noticed that they were slowing down the plaque load, and then they made the reasonable assumption that this was going to translate down the line into more clinical benefit. And and fast forward 20 to 25 years later, 20 drugs have been approved for multiple sclerosis, and you've taken many forms of multiple sclerosis and made it really manageable as a condition. And in Alzheimer's disease, that's where we're going. And we want to do it with prevention trials, so you don't have to have symptoms. Again, you can come, for example, to Banner Sun Health Research Institute. We have on the order of 30 different studies for people. Some are observational, some are treatment trials for Alzheimer's disease, Parkinson's disease, Lewy body disease, but we have some that are called prevention trials. So you can come in, and based on some testing and other things, or your family history, if you qualify, then you can get MRI scan and a PET scan. And those will actually let us know whether you have enough proteins in the brain, Alzheimer's related proteins in the brain. And then you can go into studies to remove them. And interesting enough, in those studies, when people do not have symptoms, we haven't seen really these inflammatory changes as much and the side effects as much. So that could be a benefit to you and for families. All right, I promised at the end I was going to tell you about prevention and brain health strategies. So I'm going to take 1 minute here and to finish that off. One of the main things that we found, and again, this is backed by data and science, is that not doing one thing, you have to do multiple things. So there's a thing called a finger study. It's a Finnish geriatric intervention study. They take people with a little bit lower than average memory scores, and they randomize them to doing things like managing their cardiovascular risk, exercise, brain activity, and social activity, to just tell them about it. And the good news is after 2 years, whether you're getting the coaching and do these things, or just reading about it and being involved in the research, the scores on memory, executive function, processing speed all go up. Guess what? They go up more in people who are doing this regularly and doing it in a multimodal way. So one of the main things is eat well. And that's not saying eat too many blueberries or coconut oil, etc. Eat a balanced diet. And people say, what's the diet that's had the most evidence for slowing things down? It's called the MIND diet. So you can look it up. It's MIND. It's a combination of the Mediterranean diet and an anti-blood pressure diet, hypertensive diet. Control your cerebrovascular risk. So manage your blood pressure, the blood sugars, diabetes, cholesterol, your weight. Avoid concussions, head injury, okay? Strokes, don't smoke, don't start now, and really be careful about the drugs you're taking. And people will get more and more drugs, but nobody comes in to consolidate things and take things away. 3, manage stress and promote relaxation responses. Stress is toxic. It's not just, quote unquote, in your head. There are physiological changes that with the stress response, when you have lots of cortisol and you have adrenaline and you're stuck in that gear, what that does, it's fight, flight, or just basically freeze. And what it does is it does not promote healing and building and repair in the brain. So it's very important to get into that relaxation response. Adopt a relatively, what we call positive perspectives and attitudes and a life with purpose. And there's data for that also, that when people who are very purpose-driven and have positive attitudes actually tend to do well. Connect with others and your inner self and be socially and emotionally engaged. Number 6, exercise your brain. Do challenging things. If you do Sudokus, great, but after a while you get really good at doing Sudokus. So do things that actually challenge you a little bit. Not to the point of being frustrated. Learn a new language a little bit. Play some games. Engage in hobbies. Play bridge, which is a really, really good one. And engage in lifelong learning. Participate in research. So that's really, that hits the engagement part, the connected and purpose part, and it's a do good, do well strategy. And number one is exercise. I wish I could give you that pill that does that, but exercise gives you growth factors in the brain, helps promotes repair, and it's really number 1. So in summary, Alzheimer's is in a new era. We can actually diagnose it during life. The sooner the better. If you have symptoms, do not sit at home and have people ascribe it to other things. Be active in the same way that if you had chest pain, you wouldn't go to a clinician. They just laugh it off and say, "Oh, you're just getting old," right? In the same way, if you have changes in your memory, thinking, language, you're less mentally efficient, and that's affecting things, be proactive and go get tested early. And I want to end with a message of hope, because even though these are incurable, in the last 15 to 20 years, we've learned more about this disease and diseases like it than we had in the previous 100 and something years. we're in a cusp of a new age where we can measure these proteins in the brain, and now we have drugs that can remove it in addition to our other drugs. So at whatever stage you're in, whether you want to be involved in prevention or you have symptoms, I think there's great hope for doing things. And I would say that, you know, the journey of 1,000 miles begins with one step, and we need hope in order to have a good endeavor. And that the future is actually quite bright for us. It's not going to be immediate. We're not going to cure things, but we're going to take major steps so that people now can be actually helped and future generations can be helped even further. All right, I'll stop there.
Dr. Attree, thank you so much for coming. Thank you so much on behalf of the City of Peoria and on behalf of Benevilla. We really appreciate it. And that was fascinating, and ending on hope, I think, is important. And that advice, I think, was great advice for just all of us in general. So thank you so much for your time, and I really, truly appreciate it.
Absolutely.
Thank you all for watching, giving us your afternoon, giving us your time. We really appreciate it. If you are not watching this live and you're watching this recorded, you can still ask questions. Put them right there in the Facebook post, and we will make sure to get you to the right person and get the right information. On behalf, again, of the City of Peoria and all of our sponsors, as well as Benevilla, thank you for watching, and have a wonderful afternoon.